This
Also,
conference will now be recorded.
Also, he had ulcer in his right thumb with no signs of infection or purulence. On lab results, we saw leukocytosis with predominancy of polymorphonuclears, and creatinine level was 4.77 milligram per deciliter with a baseline level of 2. The CRP level was also high with 16 milligram per deciliter. Blood cultures were drawn, and also COVID-19 PCR test was negative. Chest X-ray examined enlarged cardiac silhouette with no signs of infection, pleural effusion, or edema, and his right foot X-ray showed no signs of osteomyelitis. Following ulcer debridement and bacterial culture swab extraction, the patient was admitted to our department, our internal medicine department, with a working diagnosis of diabetic foot infection. Treatment with amoxicillin clavulanate in combination with ciprofloxacin was started. Following 2 days after his admission, the ulcer swab culture shown gram-positive rods and gram-positive cocci, and 2 blood tests indicated gram-positive rods. The gram-positive rods were identified as Actinomyces odontolyticus. The swab from the ulcer was positive for Corynebacterium striatum and methicillin-sensitive Staph aureus, but no actinomyces. Actinomycosis is an indolent granulomatous infection which normally colonizes the mouth, colon, and vagina. All organs and sites can be involved. Oral cervicofascial manifestations are the most common. A classic presentation is a painless mass in the angle of the jaw. Infection is usually limited to cervicofascial, thoracic, and abdominal pelvic regions. Following these results, we began working to detect the source of actinomyces. The patient had not undergone recent oral procedure. Exam of the oral cavity was normal, with no signs of infection. The neck exam was negative for swelling or signs of infection, with no history of abdominal procedure or acute gastrointestinal complaints. The abdominal exam was normal, with no tenderness or palpable masses. Due to the fact that actinomyces is more prevalent in immunocompromised patients, HSV serology was tested and was negative. CT scan was performed and included the neck, chest, and abdominopelvic area. Neck and abdominopelvic scan were normal, but the chest scan revealed multiple acinar opacitive, like these, and a cavitation in the right lower lobe, finding that suggestive for septic emboli. Due to these chest CT findings, the indolent features of this disease, and the fact that the patient had underwent an ICD insertion 5 months prior to his admission, we decided to move on TE. TE revealed vegetations on the tricuspid valve and the ICD electrodes. Here. Treatment was converted to penicillin, high-dose penicillin, for a prolonged period of time, and the ICD was removed the following day. A week into his admission, the patient was feeling well, afebrile, cough was improving, the CRP level were normalized, and 3 blood cultures were sterile. The patient was released from hospital with prolonged antibiotic treatment. In a follow-up visit, 3 months later, follow-up CT demonstrated full resolution of the lung disease with no vegetations that noted on recurrent TE. patient remained afebrile and asymptomatic. Actinomycosis is an indolent infection caused by actinomyces and closely related species. The characteristics include chronicity, crossing of tissue boundaries, and mess-like features. Infections caused by Actinomyces odontolyticus are rarely found. Aspiration is the usual source of infection in thoracic involvement, and the cavitary disease may develop and is more readily detected with CT scan because those cavitations are small in this kind of pathogen. While there are reports of Actinomyces odontolyticus bloodstream infections, infective endocarditis caused by this pathogen is rare, with only one case of 31 reported cases of infective endocarditis by Actinomyces. We searched for cases of Actinomyces infection on devices and foreign bodies and found multiple reports describing this organism capacity to cause foreign bodies-associated infection. For example, silicone tissue expanders infection, hip prosthesis, dialysis catheters, prosthetic valve, prosthetic heart valves, penile prosthesis, and VP shunts. All are case reports. We didn't find reports on ICD infection by Actinomyces, making this case the first reported. In our case, we believe that the most likely source of bacteremia is the ICD inserted 5 months prior. This organism can cause bacteremia, especially in immunocompromised patients like ours with diabetic mellitus and chronic kidney disease. With proper treatment, there were no clinical or radiographic signs of the disease 3 months after the admission. In summary, actinomyces is an indolent disease that has the ability to cause infection of prosthetic devices and implants. Detection of the primary source and its eradication is the most important part of the treatment. In this case, the source of infection was the ICD electrode, making it the first reported one. Thank you. Are there any questions?
Do you have any queries? I hope there are no queries from our listeners. That's a wonderful speech, Dr. Eilert.
Thank you.
Our next presenter is Dr. Ashik Babu. Dr. Ashik, are you ready for the presentation?
Yes, I just need to figure out how to share my slide.
Yes, I
So
made
I'll
you as
just
a presenter.
okay. Hopefully it'll work on my phone. It's a poster, so it should come up
Oh,
as let's see, screen broadcast.
yeah, give me a moment. I will share your presentation.
Okay.
Are you able to see the screen? Dr. Ashik?
Hello, can you hear me now?
Yeah.
I know the results. Just mainly if other people can see it. I don't know if you make it slightly larger when I'm talking about results. That's fine. So I'll be talking about essentially antimicrobial stewardship within a hospital in the intensive care, cardiothoracic intensive care unit at Hammersmith in London. And essentially, it's a closed loop audit. And the first audit, we found that patients that were undergoing cabbage surgery and wedge resection or thoracic surgery were not receiving antibiotics within an hour of the incision, which is known to be optimal in terms of the pharmacokinetics. And also, patients were not receiving antibiotics for a period of 24 hours. So that's 3 doses of cefuroxime, 2 doses of vancomycin, as per our trust guidelines. And we found that we were not getting a good uptake in terms of our junior doctors prescribing the antibiotics post-op. So we wanted to investigate why that was. So the purpose of this repeat audit was that we introduced a antimicrobial prescribing template, and it's a completely electronic system at Hammersmith. So we use something called ICA, which is used by several intensive care units within the UK, and it's the antimicrobial prescribing template comes with a set prescriptions of cefuroxime, vancomycin, alongside other useful drugs like analgesia for the patient. And we wanted to see if this had any effect in terms of how well we were prescribing these antibiotics, cefuroxime, vancomycin, and if there was any delays in administration, and if there were delays, why that was. And what we found was that since the advent of our electronic template, we had far fewer errors, and you can see that in the results section. It's quite staggering in terms of prior to the electronic template, we were having random prescriptions of cefuroxime, vancomycin, and when new doctors were coming in, they were sometimes unaware of the guidelines and prescribing completely incorrect antibiotics for insufficient doses. So we were finding more patients were developing wound infections, and we thought this could be a possible reason why that was happening. And we saw that there was at least a 40% reduction in incorrect duration of antibiotic prescribing amongst the junior doctors, and also higher frequency of patients who are receiving the antibiotics within an hour of the incision as well. So what we found was that, something that we would look into for the further audits and further investigation would be whether electronic prescribing templates does improve our antimicrobial stewardship and how we adhere to local guidelines, and whether we should have more guidelines in place, more templates in place for other post-op patients, just to make sure that the patients are getting the optimum doses of antibiotics and for the correct duration. And this reduces human error involvement in adverse effects for patients as well. So thank you very much for listening. If there's any questions, it's a very short poster audit, essentially. It's a closed loop audit, and we're planning to re-audit again over a 4-week period, just to see if the uptake, if the improvements are maintained over the next year.
Does anyone have any queries? I hope there are no queries from other listeners. Thank you for your presentation, Dr. Ashik Babu.
Thank you.
Our next presenter is Dr. Sara Al-Bosi from King Saud University, Saudi Arabia. Are you ready for the presentation, Dr. Sara?
Yes, I'm ready. Can you make me presenter, please?
Yeah, just a moment. Now you are the presenter, Dr. Sara.
Can you please let me know how can I share my slides?
Are you using the computer or a smartphone?
Yeah, smartphone, but I'm not a presenter now. I don't know why, because I was disconnected.
Let me check.
Mm.
Now you are the presenter, Dr. Sara.
Okay, thank you so much. Okay. How can I share mine?
You will have the option to share the screen. Just tap on the screen button.
Okay.
Yes, we can see your screen, Doctor. Continue with your
But
presentation.
can I send you the presentation slide and you share it because I cannot open it?
Yes, yes. You can send it me via WhatsApp.
Okay,
Yeah.
I'll do.
Dr. Sarah, I got your presentation. I'm sharing my screen.
Okay,
Let me know when to change the slide so that I can.
sure. Thank you so much. Hello,
I
everyone.
hope.
Yes, I can see it. Thank you.
Okay.
So I'm Sarah Al-Subei. I'm going to talk today about molecular biology of SARS-CoV-2, which I'm expecting most of you know about it and familiar with it. First of all, we'll go about, um, okay, you can move to the next slide. It did not change. Okay, we'll talk about the zoonotic of transmission of the coronavirus. So during the first SARS pandemic in 2002, more than 8,000 cases and like 774 deaths were reported worldwide. However, fewer numbers of MERS cases have been reported, which is 2,567 cases to date. However, only 866 total deaths have been resulted. Uh, Unlike the SARS-CoV-2, which the nomenclature of the new emerging coronavirus SARS-CoV-2 has been found to be misleading, owing to the difference from the previous SARS-CoV in both epidemiology, transmission, and unique genetic structures. Although the two viruses share approximately 79% similarity in genome structures and cause severe acute respiratory syndrome, it was suggested that the virus be named nCoV-19 to resemble the disease announced by the WHO, COVID-19. Okay, second one. So today I screenshot the WHO dashboard. As you can see, like more than 254 million or almost 254 million cases worldwide was reported today recently, and 500,000 of cases only reported today. And the disease resulted in amount above 5 million deaths. Yes, you can move to the next slide. So in this slide, we'll cover a little bit about the structure of the virus. So it's actually the coronavirus strain is positive sense single-stranded enveloped RNA, and it's belonged to the Coronaviridae family. The genome size is 30 kilobase in length and consists of 14 open reading frames, which include almost 27 proteins. At the 5 end, as you can see, of the SARS-CoV genome consists of ORF1 AB, which include for a polyprotein that is post-transitionally cleft into 16 non-structural protein. And at the end, the three terminus of the viral genome it contains all encoding for 4 main structure proteins: spike, envelope, membrane, and nucleocapsid, and as well 9 putative accessory proteins. The S protein play a critical role in promoting the cell attachment and fusion of the virus to the host membrane. It's a trimeric and contains 2 distinct domain, RBD and the carboxy terminus domain. The S1 subunit RBD protein sequence contain unique region, and this uniqueness tend to be common to the all coronaviruses in general, and it's likely to result in the intense evolutionary pressure due to the constant interaction with the host immune system. Okay, you can move to the second one. Okay, thank you so much. So in this table, I include some of the I mean, there are thousands of variants so far, but I mean, this is like in WHO, they consider it like the variants of concern because the most wise, I mean, the first one, if you can see P117, it was firstly reported in Italy in February 2020, and there was a mutation in S protein gene, and over time this became the dominant variant, displacing the original SARS-CoV-2 strain. Thereafter, additional variants have been emerging in different countries. The most widespread variants to date is number 2, which B117, as I mentioned, that emerged in the United Kingdom and was reported to the WHO in December 2020. Initial clinical studies showed that 17 nucleotide mutation or deletion in that particular variants increase the transmissibility of the virus with little or no impact in severity and diagnosis, pathogenesis, reoccurrence, or response to the vaccination. So according to the WHO report, this variant was reported in more than 137 different countries. Another variant, which is B1351, emerged in South Africa in December 18, was named B1351 after the mutation showed high similarity to the variants of the UK lineage. Okay, and you can move to the next slide. Thank you so much. So what is the distinguishing characteristic of SARS-CoV-2? It has been 3 factors has been identified as possible contribution of the virulence of SARS-CoV-2, and they might impact the pathogenicity. They include differences in the SR protein RBD, and differences in the properties of accessory protein, and the addition of a blue basic cleavage site in the S protein. So the differences are associated with accessory protein ORF33A, ORF8B, ORF6, and protein E, which is known to be involved in the inflammatory complex and innate immunity. In addition, the blue basic polybasic cleavage site, there are also O-linked glycan and RBD mutation that appear to be specific for SARS-CoV-2, and it has never been reported in other B lineage beta coronaviruses. And the insertion of polybasic site believed to be increase the transmissibility of pathogenic influenza viruses. So it's important to elucidate whether this same true for SARS-CoV-2, whether the involved insertion of polybasic actually increase the transmissibility of SARS-CoV-2. Okay, you can move to the next slide. Okay, so in this slide, I was showing exactly the difference between SARS-1 and SARS-2. In both of them, they use the same entry region, but as we mentioned, differences are the mutation happen in RBD. It make the SARS-2 more invasive and virulent compared to the SARS-1. Okay. So in this slide, I share with you what is the basic question that really need to be answered. First of all, the role of the insertion of polybasic site in increasing the binding affinity of SARS-CoV-2 to the human ACE2 receptor, and how this facilitated the transmission and the spread of the disease. This is still unknown. Second, what I know, there is like a current studies going in the United Kingdom, but we still the results not announced yet. The second, the functional significance of the accessory protein and their impact in both in vivo growth and variants of the virus are unclear. Third one, we need to understand the role of the other non-structural and host proteins in the orchestrating the sophisticated replication and transcription complex and coordinating the viral life cycle in time and space. This is also not fully understood. And finally, we need to know what enables SARS-CoV to maintain a sufficient mutation rate during trans-species movement and host adaptation. Thank you so much for attending my presentation, and thank you so much, Dr. Brian, for the invitation. Any question?
I hope there are no queries. Our next speech is by Dr. Adila Shaukat. Dr. Adila. Let me make a call to Dr. Adila Shaukat. Hi, Dr. Adila. How are you doing today? Dr. Adila? Dr. Adila, are you ready for the presentation? Dr. Adila, are you ready for the presentation?
Yes, good afternoon.
I'm making you as a presenter.
Just hold on for a while. Let me check my slides for a while.
Okay, sure.
Okay, yes, sure. You can make me a presenter.
You are the presenter now.
You can see my slides.
Yes, we can see your slides. Can you make it full screen?
Yeah, for a while.
Perfect.
Okay, shall I start now?
Go ahead.
Hi, good afternoon, everyone. It is my pleasure to present my research on this prestigious forum. So the talk is about our experience of treating Candida auris cases at a general hospital in the state of Qatar. So as we know that Candida auris, it is a novel multi-drug resistant yeast with high overall mortality. And it was first isolated from the external auditory canal of a patient in Japan in 2009. And this has been reported from various countries across the world. And it is a serious global health concern as one of the most serious emerging pathogens in the critically ill patients. So as we can see that the blue color is the one that is, the high prevalent areas, this Candida auris fungus, and the green areas are the one where few cases were reported only. So you can see there are like many countries who were reported to have this outbreak of Candida auris. So why it is important for the Candida auris, how it causes outbreak and how it is difficult to diagnose and treat. The problem is that it is resistant, multi-drug resistant fungus, and it is resistant to many antifungal classes that are routinely used for the treatment. And it poses a challenge for the identification as well. Further, it has a tendency to cause outbreaks in healthcare settings, and it carries substantial morbidity and mortality. The first published study on the Candida auris is our study that was published 2 years ago in
I'm sorry to interrupt. We are not getting your audio, Dr. Adila. Dr. Adila, we are not getting your audio.
agar, and it was incubated at 35 to 37 degrees for 48 hours. Further fungal strain identification was based on colony morphology on chromogenic Candida agar. Further identification to species level was confirmed by a Vitek2XL automated system that is actually used in our laboratory. and susceptibility of the strains to antifungal drugs like amphotericin B, fluconazole, flucytosine, and voriconazole was determined by further sensitized yeast 1 plate and by interpreting the results according to closely related Candida species and by expert opinion. So since we found many samples, so it's necessary to do pulse field gel electrophoresis that consisted of electrophoretic karyotyping. It was performed to compare the different isolates from different sites to see if there is an outbreak of this fungus. So following the result of PFGE, the outbreak of Candida auris infection in the critical care and medical unit was confirmed. And we identified 5 active cases and 8 additional patients with colonization. So this is the result. This image shows the result of PFGE from our patient samples. So the lane 1 and 2 here, these are and plus 8. These are the ones that are control specimens, whereas from 3 to 7, these are the samples from our patients. So you can see that from the lane 3 to 7, there are like same bands across throughout as compared to the other control samples. And this band variation, it shows that all these samples or strains are closely related to each other, and it confirmed our outbreak. So outbreak investigation committee was formed, and all the positive cases were strictly isolated. Other patients who were belonging to the same wards were extensively screened, and the screening sites were nares, groin, axilla, urine, stool, tracheal aspirate, or any skin discontinuity, for example, skin ulcers, or any of the catheter sites were screened. There was intensive effort done to find out the cause of cross-transmission, and that is the reason that environmental and surface swabbing was also done in all the affected areas. But from all the environmental samples, the surface swabbing turned out to be negative. But at the same time, extensive efforts were done that all the patients who are positive, they are kept separately, and the strict isolation precautions are maintained so that the cross-transmission doesn't happen to the other patients. As well as the visitor policy was also revised, and the facility transfer from other facilities or to the other facilities was also cross-checked. So there was a lot of effort done to the environmental disinfection as well. So multiple means were used to disinfect the all the like equipments and all the areas and the rooms. So these are our results. During the study period, the 13 patients that we identified with Candida auris infection and colonization, 5 of them were actually having infection, clinical infection, whereas 8 were having colonization. So as you can see that most of the patients were extremes of ages, and they are like 70 or near 70. Only 2 patients were in young age, that was 20 plus. And our male to female ratio was 77% male and 23% females. So this slide, it shows the details of the patients who were clinically infected with the infection. So you can see the ages of the patients, they are 70 plus, only 1 patient is 65. The rest of the patients are above 70, and they're all males. So the type of infection for these patients was basically one of them had candidemia out of all those patients. That is, blood culture was positive for Candida auris, whereas 2 patients were having urinary tract infection. 1 patient had skin and soft tissue infection, and 1 had lower respiratory tract infection or pneumonia. All the patients were having a lot of comorbidities, like for example, our first patient had interstitial lung disease, and he was also co-infected with coronavirus 229E PCR. Can you still see my slides?
Yes, we can see your slides.
Okay, because it was lost for me. Okay. So is it okay if I go at this way?
Yeah, okay, no problem. You can continue.
Okay. So basically, the first patient was also having a co-infection with coronavirus 229E, and he was treated with anabulafungin, and unfortunately, he died of hypoxic respiratory failure during the treatment. The second patient was a known case of diabetes mellitus, sacral bed sores, and he was also co-infected with Pseudomonas multidrug resistant and Margonella morgagni from his sacral bed sores. He was treated with flucytosine and he initially responded, but later on he died because of bacterial or fungal sepsis. Then the third patient was a known case of diabetes mellitus, CVA, and he was having sacral bed sores, co-infected again with multi-drug resistant organisms. He was treated with anabulafungin and posaconazole, and he was cured. The fourth patient was diagnosed as urinary tract infection. He was a known case of CVA and dementia, and he was treated with anabulafungin, and he was cured, fortunately. And the fifth patient was a known case of motor neuron disease, and he was admitted initially with hospital-acquired pneumonia. He was co-infected with Pseudomonas aeruginosa MDR as well. He was treated with anabulafungin, but he completed 10 days of treatment, but later on he died because of bacterial pneumonia, unfortunately. So this is like this slide shows the patients who were colonized with Candida auris infection, and you can see that all of them they were having a lot of comorbidities like chronic kidney disease, liver disease, COPD, dementia, or some of them were bedbound because of CVA. All these patients were treated just as a local application of terbinafine and statin. No systemic antifungal drugs were used, and majority of them were either discharged home or transferred to the other facilities.
Dr. Adila,
So this is the
can you zoom the previous slide?
yes.
Previous slide, so that our listeners can see
This
it
one?
clearly. Previous one.
Yeah.
Yes. Just zoom it.
Okay. Let me see if I can just open in the PowerPoint again, because that's a better thing.
Yeah.
Is it better now?
Yes.
Okay. So yeah, this is the slide you were talking about.
Yes, this slide, yes.
Yeah, is that okay, or I should further zoom in?
That's okay, good. Continue with your speech, doctor.
Okay. So yeah, so how we did our susceptibility breakpoints for Candida auris. From CDC, that is Center for Disease Control and Prevention USA, there is no current guidelines or breakpoints for Candida auris susceptibility. So basically, we decided our susceptibility pattern according to the MIC to the different antifungal drugs. So I will show you in the next slide that this is the antifungal susceptibility pattern for our patients. So you can see that all these 5 patients who were clinically positive, all of them were sensitive to anabulafungin. So MIC, if it is less than 0.5, it means it is sensitive. If it is more than 0.5, we interpreted it as intermediate or resistant. So for anabulafungin, for all the clinical samples, the MIC was good, and that's why we treated many of our patients with anabulafungin IV. The next test drug for the use for our clinical samples was posaconazole. So you can see that fluconazole in 3 of the samples was sensitive, where it's resistant in 2 of the samples. And flucytosine was used for 1 patient for the treatment, and for us the MIC for the flucytosine was also low. The other drug from echinocandins was caspofungin, that was sensitive in 2 of the samples while resistant in the rest of the samples. Amphotericin was generally resistant all across throughout our patient population, the 5 patients. And voriconazole gave a mixed picture. So you can see that there is different MICs and sensitivity pattern for all the patients, but generally anidulafungin was sensitive all throughout. So as I told already in the details before, that mainly we use echinocandins, especially anidulafungin, for our clinically infected patients. Whereas for the colonized patients, only a topical decolonization regime was used, and all these patients were kept in strict isolation precautions. So among the patients who were treated with Candida auris infection and who received systemic antifungal therapy, 3 of them died. Unfortunately, 2 were successfully treated and decolonized as well. So the overall mortality in our patient was 60%, which is in line with the mortality rate seen in the other studies that ranges from 30 to 60% as well. So worldwide, several Candida outbreaks have been reported. The first outbreak reported was from India in 2013 by Chaudhary et al., who identified 12 patients with positive microbiological clinical specimens collected between 2009 and 2012. Then later on, there was an outbreak reported by Calvo et al. From Venezuela. That was between March 2012 to July 2013. And in this, all the isolates were initially identified as Candida hamiltoni, but later on, by genome sequencing, they found out this is Candida auris. So similarly, our outbreak is the first one from the Qatar that is reported with 13 patients. And when we identified it, the major concern was to prevent the spread of this infection to the other healthcare facilities, especially the critical care. And that was the reason that intensified measures were done to control the spread of this infection. So knowing the source of infection and detecting the possible route of transmission is very important to prevent the spread of this infection and hospital outbreaks, especially among the healthcare facilities. So that is the reason that intensive efforts were done to find out the reason for cross-transmission, and infection control precautions were optimized. So in conclusion, the Candida auris, it can cause a wide variety of invasive infection, including bloodstream infection, UTIs, skin and soft tissue infection, lower respiratory tract infection, especially in the critically ill patients. It has a tendency to colonize skin, nose, oral cavity, catheter sites, and wounds, or any skin breakdowns. Identification of colonization is also very important because this is how transmission happens. And if you identify and isolate these patients, you can break the chain of transmission. Appropriate antifungal therapy should be used according to the susceptibility pattern to control and eradicate the infection. Treatment with antifungal drugs is necessary for the clinically infected cases, but however, for colonization, it is not needed, and only topical decolonization regimes should be used. Diagnosing Candida auris infection is difficult because the presentation is non-specific, and the patient can be co-infected with other pathogens, or maybe they're having different comorbidities with other conditions or illnesses. So it is important that you have a high degree of suspicion, and specialized repertory methods should be done to prevent the misidentification. And once you diagnose it, treat it successfully. So these are my references. Thank you.
That's a nice
Any
presentation.
questions? Thank you.
Does anyone have any queries regarding the presentation? I hope there are no queries. Our next speech is by Dr. Richard. Unfortunately, Dr. Richard has not arrived yet. Let's move to the next session by Dr. Mamta Banu. Dr. Mamta Banu, are you ready for the presentation? Dr. Mamta Banu. Are you ready for the presentation?
Yeah. Yes, I'm ready.
Okay. Now I'm making you as a presenter.
Yes.
You can now share the screen.
Okay. Uh, this is not highlight the share here.
Are you able to see the screen option
Yeah, I'm able
beside
to.
mute, camera, and screen? Tap on the screen. Did you logged in from smartphone or a computer?
No, it's in a laptop.
Okay.
Um, the screen option is not highlighting.
Okay. Once log out and log in.
Okay.
Or else you can share me the presentation. I will share my screen from here.
Okay. Uh, Hope now it's visible.
No. Yeah. Yes. We can see your screen right now.
Okay. Is this visible now? Can I start the presentation?
Yes, you can start the presentation. Can you full screen it?
Yeah, it is in full screen. No.
No. Yes, tap on it.
On
Beside,
this
yeah,
slideshow.
yes. Tap on it.
Okay. Yeah. Is it okay now?
Still, we are unable to see your full screen, doctor.
Okay. Uh,
Just tap on it. Yes. Click on it.
yeah, I clicked.
I see that it's not working. Okay, continue like that only.
Okay. Okay. Hello. Good afternoon, everyone. I'm Dr. Mamta Banu. I'm I'd like to present on tuberculosis prevalence in India and strategies for the prevention and control of infectious diseases. So this tuberculosis is a disease that is a bacterial disease caused by the bacilli Mycobacterium tuberculosis, which usually attacks the lungs, and it is called the pulmonary tuberculosis, but it can also affect any part of the body such as kidney, spine and brain. And that is and this Mycobacterium tuberculosis infection are at higher risk for progression if they are co-infected with the HIV patients. So according to WHO statistics for 2021, India is considered as the highest TB burden country. So going back to if you are looking back to the history of this infectious diseases, the German scientist, that is the Robert Koch, discovered this rod-shaped bacilli which causes TB on 24th of March in 1882, and the same day is now observed as World TB Day every year. From 2005 March, it is called as World Stop TB Day, and later in 1921, that is Calmet and Guerin, that they discovered a vaccine for tuberculosis, that is the BCG vaccine. So, and as the further research, an antibiotic streptomycin was found to be effective against the TB, and other drugs like INH, that is isoniazid, and PAS, para-amino-salicylic acid, were introduced so as an effective drug for this tuberculosis. So research institutions was established as a part of National TB program. In 1962, Government of India launched National TB Control Program, that is NTCP, where the drug rifampicin proved to be an excellent against this TB. The influence of TB co-infection on the progression
Excuse me,
of
Jessica, your
HIV.
slides is not moving.
It's not
Your
moving.
slides are not moving. No, we are
Okay.
still seeing the first slide on.
Uh, now?
Yeah, now it's okay.
Okay. Okay. Sorry. So I will continue from the slide 5. The influence of TB co-infection on the progression of HIV disease had higher risk of recurrence and death. So World Health Organization declared TB as a global emergency, and Government of India revised this National Tuberculosis Control Program and renamed it as a revised National Tuberculosis Control Program. So this revised National Tuberculosis Program started full-fledged globally, and almost 450 million population were covered. That is approximately more than 80% of the country were covered by this program, and by 2015 the patient deaths were reduced by 50%, and it was estimated with no deaths by 2025. So they have took an oath to make India TB free with zero deaths by 2025. But the pandemic of this 2 years, the COVID-19 pandemic, has changed all the plans. So we have to see whether we can make India TB free or not. So next, during the period in 1988 to 2005, the concept of high burden country uh, become familiar, that is HBC, high burden country, become familiar and widely used in the context of tuberculosis. In 2015, three lists for TB, that is TB, HIV, and multi-drug resistant TB, were in use. with a set of sustainable development goals for 2016 and 2030, as well as the last year of the Stop TB strategy, that is 2006 to 2015, and its replacement with the End TB strategy. So it was an ideal year to revisit the three high burden country list and consider their future. So the 30 TB high burden country were Angola, Bangladesh, Brazil, Cambodia, China, Congo, Central African Republic, Korea, and DR Congo, Ethiopia, India, Indonesia, Kenya, uh, Liberia, Myanmar, Philippines, Pakistan, Russia, Syria, South Africa, Thailand, the United Republic of uh, Tanzania, Vietnam, Namibia, and Zimbabwe. These were considered the most, that is the high TB burden country. So out of the 30 countries, so the best incidence for the global incidence and the prevalence of in global, the best global incidence estimate for 2020 are 1.3 million TB deaths among HIV negative people and an additional 2.1 lakh among HIV positive people. And the WHO TB statistics for India for 2019, that is the recently given, gave an estimate incident figure of 2.64 million cases. So the three global high burden list for TB, that is TB, HIV, and multi-drug resistant rifampicin resistance TB to be used by WHO during the period 2021 to 2025, and their areas of overlap. Countries in the TB list are those within the red T-shaped border. Countries in the TB HIV list are within the yellow border. Country in the multi-drug resistance rifampicin resistance TB list are within the blue border. So India is considered has shown considerable progress in terms of providing standard TB care in the last decade over the past few years. So as the implementation of National Strategic Plan. So the National Strategic Plan, this was an ambitious plan to achieve universal access to quality TB diagnosis and treatment that has guided activities and created accountability against uh, results. So there is a scientific increase to achieve universal access to quality TB diagnosis and treatment services for multi-drug resistance TB, that is MDR-TB in 2013, with a remarkable 93,000 persons with MDR-TB diagnosed and put on treatment till 2015. So the revised National Tuberculosis Control Program and National AIDS Control Organization have made HIV-TB collaboration efficient, and now 90% of HIV-infected TB patients receive antiretroviral treatment, that is ART, and also Government of India took a landmark move with the Ministry of Health and Family Welfare for prohibiting the import of sero-diagnostic test kits for tuberculosis. So, and there are many other new initiatives were taken as a part of National Tuberculosis Control Program. That is, one is the Nikshay app. This is a mobile app, was launched in 2012 in collaboration with National Informatics Center to contact tracing and outcomes. Details of patient registration and details of solid and liquid culture test were notified with an SMS alert to both program officers and the patients uh, on registration. So this was one of the remarkable mobile app, so which had played a very effective role in monitoring the patients of most vulnerable group. So, and there are also other strategies that are employed to stop TB in India, such as to perceive high quality dots, that is directly observed treatment, expansion and enhancement by ensuring early case detection and diagnosis through quality assured bacteriology and standard treatment with supervision. So, and one more strategy is to scale up collaborative TB or HIV activities, prevention and management of multi-drug resistance TB, that is MDR TB in vulnerable population, and to strengthen infection control in health services, to improve health policies, human resource development, and households, and also to engage all the healthcare providers to promote use of international standard for tuberculosis care, and to cooperate the private providers through public and private mix approaches. So, and to enable to empower the people with TB and community participation in TB care, prevention and health promotion were also taken care to promote the use of the patient charter for tuberculosis care. And also the last strategy is to enable and promote operational research to develop new diagnostics, drugs, and vaccines. So a new strategic plan for TB elimination, that is 2017 to 2025. So till now I have told about the strategic plan that was employed to stop TB, and later on in the 2017 we came up with the TB elimination. So TB elimination program, that is from 2017 to 2025. So that was employed for both public as well as private sector in consultation with Ministry of Health and Family Welfare. So it is a 3-year costed plan. This is a framework to guide the activities of all stakeholders, including the national and state government development partners, civil society organizations, international agencies, research institutions, private sector, and many others who work to eliminate TB in India. So this mainly aims to bring about significant change in the incidence, prevalence, and mortality of TB, and also will guide the development of a national project implementation plan, that is PIP, and state project implementation plan, as well as district health action plans under the National Health Mission. So National TB Elimination Program is implemented by the Central TB Division, that is CTD, the Ministry of Health and Family Welfare, which is supported by national level institutes and ICMR, Indian Council of Medical Research, and its organizations and thematic expert groups and committees. Committees that are formed at national level, and these are the few committees as developed as a strategy to eliminate TB in 2017. That is, one committee is the National Technical Expert Group, NTEG, on diagnosis. This is just for the diagnosis, and National Technical Expert Group for the treatment, and National Laboratory Coordination Committee, it is NLCC, and National TB Comorbidity Coordination Committee, and National Technical Working Group on Latent TB Infection Management Committee, National Technical Expert Group on Pediatric TB, so that's only for the kids, and National Technical Expert Group on Pediatric TB, Technical Expert Committee on TB in Women, including Gender Issue Committee, National Task Force for Medical Colleges, National Operational Research Committee, NORC, and National Technical Working Group on Private Sector Engagement, Technical Working Group on NETP, that is National Tuberculosis Elimination Program, Corporate Hospitals and Laboratory Collaborations, National Forum for Professional Association Working in Health and National TB Forum, and Inter-Ministerial Coordination Committee for TB Elimination. So all these were committees were set up as a national strategic plan to eliminate TB. So in a state level, we have other several things, that is the state tuberculosis officer, the principal secretary assisted by the mission director is responsible for program implementation in state, and the state tuberculosis officer based at the state TB cell coordinates with the CTD, that is the Central Tuberculosis Division, and respective districts for execution of their duties with regard to National Tuberculosis Elimination Program. And at the district level, the Chief District Health Officer responsible for all medical and public health activities, including TB control. The District Tuberculosis Center is the nodal point for all the TB control activities in the district. So at sub-district level, there is a tuberculosis unit level. It consists of medical officer, tuberculosis control, primary health care, and health and wellness center is supported by accredited social health activist, ASHAs, we call as accredited social health activist, and all they support in the tuberculosis unit level for the elimination of TB. So the national policy that is employed for the diagnosis of tuberculosis is the microscopic examination, that is the direct sputum, that a smear of the sputum was taken and observed under the microscope. It was stained by the Ziehl-Neelsen, or it is also called acid-fast staining, as this mycobacterium is acid-fast bacteria. Conduct these stain, or it can also visualized by fluorescent microscopy. So, and the second test is the now it is this is the widely used test, that is nucleic acid amplification test. Um, in that we have CBNAAT, that is cartridge based nucleic acid amplification test, and TrueNAT. TrueNAT, it is also a nucleic acid amplification test, but also with the antibiotic resistance test. So within 1 to 2 hours we can get the result of this. And the x-ray, chest x-ray for early diagnosis and initiating appropriate treatment. So these are the diagnostic methods used in the national policy. And for drug resistant tuberculosis, patients at high risk of multi-drug resistant are diagnosed using nucleic acid amplification test. All rifampicin resistant patients are subjected to line probe assay, and response to treatment for multi-drug resistant tuberculosis is monitored by follow-up culture on liquid culture mycobacterium growth indicator tube. And there are several strategies that is adopted for case finding. So first is the positive case finding. Patients with symptoms of TB voluntarily seek health care. So that is positive case finding. And intensified case finding, screening patients attending health facilities with comorbidities for TB like HIV, case finding diabetic Clinic Tobacco Nutrition Rehabilitation Center. So this is a provider initiated screening for outpatient active case finding, actively searching for TB patients among vulnerable population in the community, and vulnerable mapping is done, followed by periodic screening of vulnerable population. So this is the evolution of strategies for improving the case finding. The program has a very well established quality assurance mechanism, which in line with the World Health Organization system for hierarchical control from the highest level of national research laboratories to state research laboratories to the district and sub-district level, and the district level to the most peripheral level. The quality assurance has all elements of internal quality control, on-site evaluation, and external quality control. So over the recent years, India has been successfully inching its way towards bridging the gap between the World Health Organization estimated number of incidents, new plus relapse incidents, TB cases, and the number of incidents TB cases notified by the National TB Elimination Program. However, the COVID-19 pandemic derailed the momentum gained by the TB program. Like all other national programs, the routine TB related services were adversely affected across the country due to COVID containment measures. In 2019, the National Tuberculosis Elimination Program achieved a notification rate of approximately 159 TB cases per lakh population against an estimated 199 per lakh. So TB case notification started picking up by the end of 2020, a total rise of 11% from the projections made around April end. So the age sex distribution of notified TB cases in 2020 is TB affects people of all genders and all age groups, but the men accounted for 61% of all TB cases in 2020. Children 0 to 14 years formed 5.65% of the total TB case. The age sex notification distribution shows that there is a preponderance of TB among the age group of 15 to 30 years for both male and females. So that is and the home remedies for tuberculosis. We use several Indian made. This is some traditional thing. The nutritional support is always considered a good adjuvant therapy for TB patients. The government of India provides financial support to all the TB patients for their nutritional needs under the Nikshay Poshan Yojana, so NPY scheme through direct benefit transfer, and all these nutritional supplements were given free of cost to the TB patients. So there are so coming to the conclusion. So globally, every year 2020 witnessed the year 2020 witnessed a COVID-19 pandemic devastated lives, economies, health system, and public health programs across the world with record-breaking speed. COVID-19 disrupted ongoing TB elimination efforts and services all over the country. So now we are working on interrupting the chain of the transmission by early case detection and prompt treatment in the cornerstone to achieve TB elimination. So all these efforts for TB case finding at every level, from the primary health center to the National Tuberculosis Research Laboratories level. So um, we are finding efforts, making effort to find the TB cases as soon as possible and taken care. so that TB can be eliminated by 2025. So this is my presentation. This is what the TB in India, tuberculosis incidence in India, and the strategic plans that government of India has employed to control, to eliminate TB from India. Thank you.
Thank you for the presentation, Dr. Mamta. Does anyone have any queries regarding the tuberculosis presentation? I hope there are no queries.
Okay, I thank the organizers for giving me this opportunity to present about tuberculosis incidents in our country. So thank you very much.
You're welcome. The next presentation is by Dr. Richard from AI Pharma Lab, United Arabs. Dr. Richard, are you ready for the presentation?
Yes, ready to go.
Yeah, I'm making you as a presenter.
Okay, perfect. While we're waiting, Dr. A very informative presentation. Thank you very much.
Now you are the presenter, Dr. Richard. You can share the screen. Yes, the screen is visible.
Can everyone see this screen?
Yes.
Okay, beautiful. So hello, good morning, and good evening. It's a great pleasure to be able to speak at the Global Summit on Infectious Diseases 2021. I understand that the theme of this year's conference is Global Strategies to Treat Infectious Diseases. And today's presentation, I'd like to focus briefly the discussion on oral antiviral drugs, specifically favipiravir, along with the optimal timing for initiating antiviral therapeutics. So the disclaimer, I'm going to go ahead and skip that. So before we actually get into the subject of antiviral therapies, it's important to note that more than 255 million cases of coronavirus have been confirmed to date, with more than 5.1 million deaths. So a good place to start off this discussion would be on favipiravir, on what kind of drug this is and what sort of mechanism of action this particular oral antiviral offers. So favipiravir is a small molecule nucleic acid analog. It's an oral pill, and it's very well absorbed after administration. The drug and the compound specifically target viral RNA-dependent RNA polymerase. So the way this works is favipiravir, after ingestion and absorption, is first incorporated into the host cells. The drug is then converted to favipiravir ribofuranocell phosphates by the host cell enzymes. The triphosphate form, which is favipiravir RTP, is the actual compound that inhibits viral RNA polymerase activity. So we like this drug specifically because it has a very broad spectrum antiviral activity against genetically unrelated viral families. And we'll get into that in our next slide. So this slide describes or illustrates the broad spectrum activity of favipiravir against a broad host of RNA viruses. This includes influenza viruses, which the drug was originally developed for. It also includes arenaviruses, Lassa, Hanta, Ebola, Marburg, etc. While the drug is generally considered very safe with a very reputable safety profile, there are a number of contraindications that we should be discussing. Specifically, the drug is absolutely contraindicated in women who are either known or suspected to be pregnant. This is because of the risk that we've seen in animal studies of potential early embryonic death or teratogenicity. So thank goodness we've treated more than 1.5 million patients worldwide with this drug. We've been very careful about how we instruct our physicians on the ground on how to administer the drug and what to be mindful of. And I think we're very happy that we have an excellent track record for safety, and the legacy has been maintained with regard to not having a single case of human embryonic death or human teratogenicity associated with the use of this drug. And this is a legacy that we hope and will emphatically ensure that it is maintained throughout the years to come. So a little bit on the efficacy end of the discussion. This is a Japanese observational trial that was conducted and is ongoing actually on favipiravir. The study design actually involves more than 490 centers throughout Japan. It has recruited more than 2,200 patients to date. And the patients, given the observational nature of this trial, there is no control arm, but the patients who were administered favipiravir were given the drug at a dose of 1,800 milligrams BID, followed
Dr. Richard, sorry to interrupt. We are unable to hear audio. Dr. Richard? Dr. Richard, we are unable to hear your audio.
I just sent
and
Richard a
60%.
message.
Yes. Now it's perfect.
Oh, sorry.
Richard, you dropped off there for a moment with your sound.
Got it. Can you hear me now?
Yes.
Okay, beautiful. So 14 days after administration of the drug, you see the percentage of patients who improved in each of the clinical categories improved to 88%, 85%, and 60% in the mild, moderate, and severe disease categories, respectively. So of course, whenever we're talking about a novel therapeutic, we have to balance out the efficacy with safety. And in this Japanese observational study, they did just that. They looked at the number of adverse events and the what type of adverse events were identified in this ongoing observational trial. They found that 15% of the patients did present with transient hyperuricemia, and 7.3% of the patients presented with elevated. So basically, the Japanese observational trial is great as it gives us a slight indication as to the efficacy and safety of the drug. But again, it's not a controlled study. So here is an actual controlled study that came out of China in the earlier phases of the pandemic. And it's a study that was designed to evaluate, again, the efficacy and safety of favipiravir on COVID-19 patients. It was an open label, non-randomized trial, which had two arms comparing favipiravir with the Coalesce drug, Coalesce being a combination of lopinavir and ritonavir. The primary endpoints that they applied in this study were viral clearance and improvements in chest CT. So you can see here that the median time to viral clearance was significantly shorter for favipiravir when we compared that against the combination of lopinavir and ritonavir. The actual days were 4 days in the favipiravir group versus 11 days in the Coalesce group. So this is an interesting finding that's associated with this study. In addition to that, what was interesting about this study was actually observing the changes in radiographic findings. And what they found was 14 days after using the drug, they found that the improvement rate observed in the favipiravir patients was significantly higher compared to the patients who were given lopinavir and ritonavir at a rate of 91.4% versus 62.2%. They also did examine the number of adverse events, and in this study, they found that the total number of adverse events in the favipiravir arm of the study was 11.4%, which was actually significantly less than the comparator arm, which was the lopinavir-ritonavir combination group, which found adverse events in more than 50% of their patients. So another study that came out of China, which was interesting, was a comparison between favipiravir and another drug that we don't commonly use in Europe or the US or Japan called umifenavir. Umifenavir is a drug that's commonly used in China or Russia to treat influenza patients and other viral indications as well. So in this study, they were looking to compare the clinical recovery rate at 7 days from the start of treatment as their primary endpoint. So what they found was for ordinary patients with COVID-19, the 7-day clinical recovery rate for Arvidol or umifenavir was 55.8% versus 71% with the patients who were placed on favipiravir therapy. And these results were significantly different between the two groups. For ordinary patients with COVID-19 and patients with hypertension and or diabetes, so these are the patients with high risk factors, the time of fever reduction and also cough relief in the favipiravir treatment group was also significantly improved. We can see this on this slide. So we can see on the left-hand side of your screen, you can see the latency to pyrexia, followed by cough relief on the right-hand side of your screen. Again, the adverse events that were documented in this particular study were pretty much consistent with that observed in many of the other studies that have been conducted prior to this particular study, and also studies that have been conducted after this study was published as well. The most common adverse event that we associate with the use of favipiravir is the transient serum uric acid levels that are elevated. And again, the key word here is transient. Once we stop the treatment, the elevated uric acid levels return to normal quite rapidly. So those were smaller scale phase 2 trials. And in recent months, a Japanese team headed by Dr. Shinkai conducted a phase 3 trial in Japan. And this was a randomized, single-blind, placebo-controlled parallel group comparison design. What they did was, we already had sufficient background on previous studies and on what the efficiency for efficacy was and also for safety. So we already had a general knowledge that the drug would work in a certain way in this population. So what they did was they assigned the patients on a 1 to 2 basis into the favipiravir arm and also the placebo arm. So 107 patients were enrolled in the favipiravir arm, 49 patients were enrolled in the placebo arm. So again, a total of 156 patients, 49 assigned to placebo, 107 assigned to favipiravir, and the results were based off of a composite outcome. And that composite outcome was defined as the time to improvement in body temperature, so how quickly the fever improved in these patients, also oxygen saturation levels, the findings on chest imaging, and SARS-CoV-2 negativity. It's important to note that the patients who were enrolled in this study, one of the inclusion criteria were that the patients were diagnosed with mild COVID-19 pneumonia. So that means the patients already had to have signs of inflammatory responses in their lungs, and this was one of the prerequisites. The median time to meet the primary endpoint that we discussed above, which is the composite outcome, was 11.9 days in the favipiravir group versus 14.7 days in the placebo group. Now, it's easy to confuse this and assume that 11.9 days and 14.7 days is actually pretty slow when we consider how quickly the average patient in the outpatient setting improves from their symptoms. But again, it's important to stress here that the patients enrolled in this study were patients with COVID-19 pneumonia. So of the individual COVID-19 symptoms, what we had was we noticed improvements, significant improvements in the alleviation of a certain number of symptoms associated with COVID-19. These include headache, myalgia or arthralgia, and also fatigue or tiredness. The other symptoms that you see on screen here showed no statistically significant differences between the two groups. The difference in the cumulative chest imaging improvement rates were actually pretty different, and they became increasingly apparent over the clinical course of the patients. So you'll notice that, on day 4 and day 7, there really was no statistically significant difference, but the real changes were noted in the patients after the day 10 mark. And after that, after day 10, we also did an analysis on day 13 and 16. All of those days, we could see that there's a significant difference between the favipiravir arm versus the placebo arm. So I think it's really important that before we summarize and conclude this presentation, it would be a great learning experience for all of us to revisit the theme of this year's conference, which is Global Strategies to Treat Infectious Disease. There is no global strategy without antivirals, but when we're discussing the criticality of antiviral treatment, it's important to understand viral load dynamics, as it allows us greater insight into the optimum therapeutic window for COVID-19. So after the initial exposure to SARS-CoV-2, as you can see on this graph, the patients will typically develop symptoms within 5 to 6 days. The exception, of course, has been the Delta variant, which has an incubation period of about 4 days or less on average. So the graph, or this curve for the viral dynamics, does shift to the left a little bit for the Delta variant. But aside from that, this graphic is a pretty good representation of how the virus replicates in the host after exposure. So with that said, in general, the viral load does peak out within the first week of infection and thereafter naturally declines. So keeping that in mind, let's take a look at this graph. So the antiviral therapy is extremely challenging, and this is not only for COVID-19, but for other acute viral infections, because antiviral therapies must be given early in the infection process to be effective. This is not only true for COVID-19, but for other more common acute viral infections, such as influenza. So the cardinal rule for successful antiviral therapies is engaging that narrow therapeutic window, however challenging that may be. So on screen now, we see a number of important antiviral studies that have been plotted in accordance with the mean number of days from onset of symptoms to randomization or treatment. So although a number of these studies have shown some pretty promising results, none of these studies are what you would call groundbreaking. And perhaps there's a simple reason for this. As you can see, the vast majority of the patients enrolled in these studies were administered the drug more than 7 days after onset of symptoms, which basically falls outside of the optimum therapeutic window. So you can see that the viral load here has peaked out long before any of these antivirals were engaged. The earliest intervention conducted by the Shinkai et al. Study, the phase 3 study that we just discussed, was able to get the drug into the patients on a mean number of days of, I think, 5.9 days. So 5.9 or 4.9 days. And even with that, we're still towards the natural alleviation of the viral load peak out at that time of engagement. So the big question is this: if we know that none of these studies have actually reflected the potential of real-world use of these drugs, because when we're trying to enroll these patients into these studies, they have to go through a pretty intensive screening process. making sure that they hit all the marks for the inclusion criteria, making sure that they don't infringe on the exclusion criteria. So that screening process will take anywhere between maybe 1 day or 2 days. And by that time, it's very difficult to try to engage patients 1 or 2 or 3 days after onset of symptoms. But with that said, the question still remains, have we recognized the full potential of antivirals using these studies when the timing was suboptimum? And I think the answer is a resounding no. And this is not only with regard to favipiravir, but also remdesivir and other antivirals that are currently out there. So in conclusion, there is a growing body of evidence that supports the efficacy for COVID-19. There's more than 50 clinical trials to date that are either ongoing or that have been completed. A series of promising clinical investigations has led to the approvals for favipiravir for emergency treatment of COVID-19, and the drug has currently been approved in 9 countries and counting. The safety of the drug continues to be well documented. There are no new unexpected or new serious safety issues that have been reported with favipiravir in COVID-19 studies. The data is consistent largely with the previous safety studies. And the most common adverse event associated with the use of the drug, as we discussed earlier, is the transient hyperuricemia. Again, this is very manageable and reversed after stopping drug administration. We also found that the safety profile of favipiravir, with exception to the hyperuricemia, was found to be similar to the placebo in randomized control studies. That concludes my presentation. Thank you very much for this opportunity, and I welcome any questions. Thank you.
Does anyone have any queries regarding the speech by Dr. Richard? I hope there are no queries. That's a wonderful speech, Dr. Richard.
Thank you very much.
Let's take a lunch break as per the schedule, and let's meet at 13:30.
This conference will now be recorded.
And after that, we just applied the APDT, and we did the analysis about the metabolic activity of the biofilm. We also used the SEM to visualize the effect of these 2 therapies, and to check if these therapies are efficient against the EPS. We did some analysis, especially determining to quantify the proteins and carbohydrates once they are the main compounds into the EPS. Here there some of the parameters that we used. The LAD was the light that we used to apply the APDT once we decided to use the methylene blue. That's the photosensitizer, and the methylene blue absorbs in the red light in the 630 nanometers. These are the time of the radiation that we use the red light, the fluence, and the light dose, the concentration of the methylene blue, and to understand if the combination of both therapies are efficient or not. We did the control using only the APDT, and only we applied the electroporation, and these are the conditions of the electroporation that we applied. After the experiment, we just have here the results. The first graph, we can see the survival index that we performed using the XTT, checking the viability of the cells. As you can see, only the controls, that is only the methylene blue, only the electroporation or the light, they do not promote a very significant effect against the cells. And the APDT per se can just kill more than 50% of the cells, that if you compare with the antibiotics that we can see in the literature is more efficient than the antibiotics that we are being used against the MRSA. And when we apply the both conditions together, we can just reach a high concentration of the inhibition of the cells, almost killing 100% of the cells that is inside the biofilm. This can be because we using the both therapies, we could like reach almost kill the biofilm, because we disrupt the EPS. If you can see here, then the quantification of the proteins and carbohydrates was very low if we compare with the control. Once the both therapies could disrupt this EPS, and that's why it's reached the deeper cells of the biofilm, and the electroporation opened this EPS and allowed the photosensitizer to go deeper to the biofilm and could just inhibit almost 100% of the cells. This is the images. And the images here, you can see the control. The control, we can see biofilm, and we can just zoom here. We can see the whole biofilm format of biofilm of the Staphylococcus aureus. The electroporation only. The electroporation caused some disruptions between the biofilm. What explained that with these disruptions, the photosensitizer could reach the deeper layers of the biofilm and kill almost 100% of the cells. Only APDT, as we can see here, most of the cells was just killed, but some of them just continue to be here. And if we put these cells in contact with nutrients, they will regrow again. And that's why the biofilm is necessary to kill almost 100% of the cells, because once they are in contact with the nutrients again, these infections can be continued. So when we just perform the both therapies, we cannot see the whole area of the surface. Is almost empty. Only some cells that rest, and these cells are damaged. Once, if we try to put these cells to regrow again, they will not be able to do it because they suffer damage and they are just dead. As a conclusion, we may suggest that the electroporation possible increase the EPS, the electroporation possible increase the EPS permeability, allowing the photosensitizer to reach the deeper cells in the biofilm, and consequently, the deeper cells will just be killed by the APDT, intensified the APDT effect. This is just the first step that we are doing in this study. We needed to perform more experiments to check the proteins, to see how is the lipids and everything. So thank you so much for your attention. If you just have some kind of questions, I'm happy to just share and answer.
I have a question. Can I ask?
Okay. Yeah, sure.
Yeah. Hi, Dr. Vanessa. Excellent talk. Yeah, I wanted to ask how exactly you electroporate biofilms, because my image of electroporator is like we have a cuvette in which we put the cells and then do the electroporation. So how do you do that with biofilms? I missed some part of your talk. I lost connection.
Well, I perform it. I will just return. Can you still see my screen, all right?
Yes, I can see.
Yeah, so as you can see here, I performed the biofilm on a cellulose membrane. And this cellulose membrane, I insert into a cuvette. And into this cuvette, I add the methylene blue solution. And after that, I apply the electroporation parameters.
Okay. Now I understand it.
Yeah.
Okay. Thank you.
You're welcome.
Hello.
Hi.
Yeah. So, hello. Can you people get me?
I'm listening. Hello.
Dr. Adam, do you have any query related to the presentation? I hope there are no queries. That's a wonderful speech, Dr. Vanessa.
Thank you.
Let's move to the next presentation by Dr. Adam. Dr. Adam, are you ready for the presentation? Dr. Adamu, are you ready for the presentation? Hello, Dr. Adam. I made you as a presenter. Kindly share your screen. Dr. Adam?
Hello?
Yes, Dr. Adam, we can see your screen. Dr. Adam, please deliver your speech.
Hello? Hello?
Yes, Dr. Adam, we can hear you. Continue the
Hello?
presentation.
So it means the prevalence of, when you see the prevalence of hepatitis B and C is alarming in the world, and then you see that hepatitis B and C is two among the common types of hepatitis B, that the comorbidities in HIV patients is highly evident. And you can see the prevalence of hepatitis B and C in the close related areas in Cameroon, as in Buea Regional Hospital, to be 6.1%. And then now you go to the prevalence of hepatitis C among HIV patients in a cohort studies that was carried out in Switzerland, and you have 37.2%, according to the scientists presented in the print. Now, following two systematic reviews that was carried out suggested an overall prevalence of 3% among the people with HIV in the sub-Saharan Africa, and the variation was between 0 to 55%. Sub-Saharan Africa has been the highest infectious disease and thus remain the epicenter for global HIV epidemics. Despite this, data for hepatitis B and C are lacking due to limited diagnosis capacity and lack of prioritization in public health programs. Sub-Saharan Africa have the highest infectious disease and thus remain the epicenter. Now, a study among HIV patients in the Northwest region and full community in Cameroon showed the prevalence of hepatitis B to be 12.6% and then 8.9% respectively. This study does not present the information concerning demographic risk factors, stage of HIV infections, and the viral load. Now, the study of hepatitis B and C among the HIV patients aged 21 years and above at the Buea Regional Hospital presented respective prevalence of 6.1% and 2.8%. With increasing access to ARV therapies and in the increasing of the infectious disease, the latter among patients in resource-limited countries is expected to increase at all ages, contrary to the case in Europe and North America. Cameroon's national guidelines for clinical management of HIV recommend screening for viral hepatitis. Unfortunately, standard practice in Cameroon, it does not include this baseline laboratory test. Given the lack of such data in the health district database, there is a need to ascertain the scope of viral hepatitis burdens among the patients in Kubahe district, which will contribute information in future health policies and decision making in Cameroon. So now, when you look at HIV infections, you see the the manifestation of HIV infections once a person is infected. You see when before HIV infections, you see before HIV infections, and then you have the onset of the infection, and you see in weeks, that is say 2 to 4 weeks, you see how the HIV virus start manifesting, and then in the different stages attacking the red blood cells. And now you have the window period over some time that the HIV period here, there is presentation of high signs and symptoms, and then it crosses the window period, it start reducing, and then you can see how the blood cells, CD4 cells are reducing. And now you have the different stages. And now when hepatitis, it is aggravated in the presence of hepatitis B and C co-infections. Now looking in the wall, you see the different genotypes of hepatitis B in the wall, and you see the distribution. I see that it is endemic in Africa and not living out Cameroon and in the northern part of the Asia. Now, when you go to hepatitis C, the different genotypes with the different color indicators show the different genotypes that are found in the different countries as presented. Now, concerning the general objectives is to determine the burden of hepatitis B and C virus in patients in Kumbahe district, as more specifically to determine the prevalence of hepatitis B and C infections among HIV patients placed on HAT in Kumbahe district in the southwest region of Cameroon. We had to identify possible risk factors associated to the high prevalence of hepatitis B and HIV patients in Kumbahe district. Now, to monitor the immune response of through CD4 cell count, viral load, and weight after every 6 months for 24 months among the co-infected patients placed on HAT, to evaluate the liver toxicity of level of alert, ASAT, bilirubin, albumin, and creatinine, and renal functions after every 6 months in the infected patient placed on HAT treatment, to evaluate the risk factor associated with treatment outcomes infected patients after 24 months of HAT in Herb district in the southwest region. Now, location of the studies area in Kumbahe district in the southwest region of Cameroon. Health facilities concerns were Kumba District Hospital, you have Same and Kumba Town, and the Apostolic Hospital, Banga Bakundu. Now, concerning the sample size determination, we calculated using the population proportion of 6.1%, which was the district with the closest that came out with this at 99% confident interval of this total number of patients were placed on treatment in Kumbahe district as follows. Now, the following formula were used to determine the sample size. That was 299% HIV client involved in the determination of prevalence of hepatitis B and C in Kumbahe district. Now, concerning the sampling method, 3 out of the 5 treatment centers were selected, which was Kumba District Hospital with this total number, same in Kumba Town with the total number, and then Apostolic Hospital, Banga Bakundu with this number. Now, the sample size per size above were this and this respectively. The patients' files were selected per site after every 16 files. After every 16 files. So they were put in order and then selected after every 16 files. Now, concerning the study design, it was a prospective cohort through administration of semi-structural questionnaires to participants and collection of sample. Cohort of patients involved for the 12 months follow-up were follow and hepatitis B and C patients free of TB and almost on all the patients. So it means for the part that concerned follow-up, we did not include all those that have not been on treatment, has been on treatment for more than 1 year. If you were TB, you are excluded. Ethical clearance were obtained from International Review Board, Faculty of Health Science, University of Buea. Now, 299 patients were tested for hepatitis B and C, during which all the positive cases were confirmed by the use of ELISA. For the prospective cohort, 52 HIV patients, 36 HIV hepatitis B, and 12 12 HIV hepatitis C were followed up for 12 months at the various sites. The data resulting through questionnaires and sample were entered in a data capturing sheet and analyzed using PCSF 20. Now you see the kind of reactions that were occurring in the for antigen antibody reaction. You have antigen antibody reactions, hepatitis B surface antigen or anti-hepatitis C antibody. Those the reaction occur indicating that there was the positive result where with this number of lines, and then these positive clearance were confirmed using ELISA. We realized one color line at the control region, non-appearance at the test site. So now, to concerning the enzyme-linked immunosorbent reactions to confirm the presence of antibodies in the patient sample, we took the patient sample and then we have antibody already fixed, and then we added the targeted protein. After adding the targeted protein, we added enzyme label antibody, which recognize the targeted protein fixed to the antibodies, and then we realized a reaction. We realize a reaction between the two. Now, living from here to here, we had these colorations in the different ways. Where intensity of coloration was due to the presence of target protein in the system. And now, after this was done, we added sulfuric acid to stop the reaction, and then the absorbance was red, and then increase in absorbance indicated the increase in the presence of a protein being looked for. It was indirect ELISA with incubation at 60 minutes, 30 minutes, and 30 minutes at 37 degrees centigrade. Wells were soaked 2 to 30 minutes and washed at all the steps. Absorbance rate at 14 nanometer. This reaction confirmed the presence of antibody linked to the hepatitis B and C in the test sample, hence positive result. So now concerning the social demographic of patients. Participants in Kubahe district, you see the three sites with this variation and the percentage of the people in the female sex were 208 and the male sex were 91. Concerning the age range variation, you see how the most represented age range, those that were highly positive for hepatitis, for HIV in Kubahe district were this age range, followed by this age range. And now, level of education, no formal education. You see, primary level was up to this, which indicated that the population are having low knowledge concerning the distribution of some of those diseases. Now, taking into consideration these factors, people were cohabiting, single or married. Now, you see the total number of people were cohabiting, married, and then widows, Christians, Muslims. The majority of the people were Christians. And then applicants, those that did not have anything doing. So you see, farmers were the highest with HIV, which were HIV positive patients. Now coming to areas of residence, you have urban, rural. Now you see rural was a factor. Now, have you ever received blood from someone? You see, those that were yes, only 32, and then no from those other ones. So now overall level of participant knowledge on the mode of transmission and the signs and symptoms of this hepatitis B and C in Kubahe district, you have 26.8% had good knowledge and 73.2% had poor knowledge. So this indicates the high spread of infections among the clients from rural environment. So now, concerning overall participant knowledge on the mode of transmission and signs symptoms of Kubahe district, you see, concerning hepatitis B, you see 26.4% had good knowledge, then 73.6% had poor knowledge of this. We can really see the low level of knowledge as a contributing factor to increasing the prevalence of hepatitis C infection among the populations in Kumbahe district, which is a call for concern. Now, looking at the prevalence of hepatitis B and C by RDT rapid diagnosis test, we see 12%, by ELISA we see 12%, 83 were negative. Now, in similar manner, this prevalence was slightly similar to that obtained in Australia, which was 13.7% by this and this. And then in the northwest region of Cameroon, 12.6% by Zofale et al. Now, concerning the prevalence of hepatitis C among the patients, we saw 4% of the patients with RDT, and then 4% were also confirmed with ELISA. Now, the prevalence of those that were not, these were negative. On the other hand, this prevalence was slightly similar to those obtained in systematic review among people living with HIV in sub-Saharan Africa, which was 3%. Now, if you see the prevalence of hepatitis B and C by socio-demographic characteristics and associated risk factor, you can see that same result was obtained in this by Justin et al. With this percentage greater than this. Now, looking at the different age range, we realize that this age range less than 15 years, according to this 20th century, was at 0%. Meanwhile, the age range that was highly affected by this prevalence was this one, with the prevalence of this and this concerning hepatitis B and C, with the p-value equals to this, with the now concerning the prevalence of this prevalence of hepatitis B and C by social demographic association, we have those that were highly affected. You see in the different percentages in the, and then you see the absolute figure which was when calculated. Yes. So if you can see the different prevalence, you see that Christians were highly affected with hepatitis B and OC, while Muslims were less affected with the hepatitis B and C. And most of these things depend on the culture. And you see the farming people too, also the highest prevalence and applicant, who are those not unemployed. So now looking at the area of residence, urban, rural, you see that the rural part is the one which is having high prevalence of hepatitis B at p-value equals to this. And then you see this other one too. Now, if you go to, have you ever received blood from someone, you see those that received blood were so low, and no, this one which indicated that it is this particular factor that is the contributing factor for the spread of this infection. Now, take antiretroviral regularly, you see no, very few, and then you see yes, few. So it means not taking antiretroviral, not taking antiretroviral is a contributing factor for spread of this. The knowledge category on hepatitis B and C, good knowledge of hepatitis B, and then poor knowledge on hepatitis B, you see. Yes. Yeah, so you have good knowledge, you see. So now concerning the ever receive blood from someone, you could see concerning the associated risk factor, we see the reference. All this reference means those were something that could be no. Now, if you see vehicles here, it means it was yes, which means it was a contributing factor to the spread of the infection. The same as treatment centers, Kumbahe district, you have this, and then you have Apostolic Hospital, this at p-value equals to this. Now, Nkuba Subdivisional Hospital is a reference. It means being in the Nkubahe Subdivisional Hospital have a risk ratio reduced for the activity. Now, you have level of education too for hepatitis B and C as a risk factor. Take regularly antiretroviral. No, you have all of these factors which make this now poor knowledge on this now is like a duplication of what I was presenting. Now, knowledge category on hepatitis C. So now, concerning the effect of hepatitis B and C on response to heart in HIV patient during the 12-month available, to monitor the immune response, 52 HIV patients free of TB at most at stage 3, not option B, and less than 1 year, 36 hepatitis B HIV and then 12 hepatitis C patients were gotten from the previous 290 participants. Immune response was monitored through the evaluation of weight, viral load, and say, following the variation of the weight from the month of 1 to the 24, because this research was here to here, but we have already carried from here to here, which is from here to here in month 12, and then we proceeded from month 12 to month 24, which has not yet been published, except an increased body weight during the first 6 months. HIV, hepatitis B, and HIV, hepatitis C patients, there was no significant change in their parameters during the first period of the month, as see the graph indicated. Now, looking at the CD4 cell count, in the HIV hepatitis B patients, so you see CD4 cell count for HIV patient is increasing. It is increasing for a period of 12 months, and when we proceeded, it went up and then went up. And then it for all Bobovi increases from 1, 6, 7 up to 24. Now it means CD4 for this was greater than this patient, but there was no significant change in p-value for the first year for both patients, while CD4 count regularly drops in some of the hard-treated patients. For viral load, it was seen that the viral load was dropping. It started from this patient, but for this compared to this, it means that this hepatitis B and OC contribute to, you see this one was very, very low, and then this one now contributed, make it to be high due to some liver damage at p-value less than the, which was statistically significant. So difference in adherence to treatment and other factors such as alcoholic status, because some were taking too much alcohol, was a contributing factor for this activity. Liver function for HIV, hepatitis B and C co-infection from month 1 to month 24. Whether mono-infected or co-infected, there was significant decrease in alert and ASAT over baseline to 24 months. The co-infections were whether for hepatitis B or hepatitis C level had significant increase in this of transaminase level. The follow-up period compared to mono-infected patients. Now, when you look at the variation of alanine aminotransferase in the HIV patients, early, you see it far down here, and then when you look at this one, you see it far up here, meaning that there was effect on liver damage. But when you look, the curve are going down, indicating that despite the fact that there is hepatitis B and C, which has increased the level of this to be high up here, with regular therapy, there is reduction. And then looking at alpha aminotransferase, you see the same trend going down now, but there is liver damage which was not so intense. But we noticed that continuous regular consumption of antiretroviral is a contributing factor to lowering some of those parameters and preventing not to go higher, which indicate liver damage. Co-infection of HIV patients with hepatitis B and C increase the albumin and total bilirubin level in the blood level. There was noticeable decrease in albumin co-infected patients in 12 to 4 months from both 1 to 14. Bilirubin gradually decreases. Co-infection patient with HIV patient, it start decreasing from month 6 to month 7. Now looking at variation, the similar variations in albumin and bilirubin level. So we realize that HIV patient is always down, and then now this one is always up. But although it increases going down, but this one increases more higher, which indicate that the liver is not being damaged. Similar strengths here. And you realize that this same result was obtained by Dore et al. In 1990 with the similar strength and presentation. So now, regarding the creatinine level, co-infection of hepatitis B and C with this or this led to significant increase at p-value less than this. There was a general decrease in creatinine level in mono and co-infected patients from month 6 to month 12, while there was a total decrease for this from month 1 to month 24. So looking at the trend, you see that HIV is below, and then you see this and this, but all are going down following regular respond to heart between the different intervals of consumption of this thing. So now there was a respective prevalence of this concerning conclusion. There was a respective prevalence of 12 and 4% for both hepatitis B and C in Kumbahe district. It's worth noting that most people in Kumbahe district still have a good understanding of causes and signs and symptoms and the mode of transmission of hepatitis B and C. Throughout this study, we observed a gap in all variables, mono-infected and co-infected patients during the whole period of treatment. Now, HIV disease following heart do not appear to be adversely affected by hepatitis B or C co-infection after 24 months follow-up, but it seems that there is a response to heart between mono-infected compared to co-infected patients, taking into consideration the weight, CD4 cell count, and viral load. Concerning the renal and liver functions, we observe a decrease in the biomarkers in response to heart over 24 months. Routine screening of people living with HIV for hepatitis B surface antigens and hepatitis C antibodies considered, and drugs that target both infections should be included in the treatment protocol. Now, with concerning the perspective, with long-term period greater than or equal to 5 years to really know the effect of hepatitis B and C virus on HIV patients, to quantify the level of hepatitis B and C in the patients for place on concrete management protocol, to characterize the different genotype of hepatitis B and C among the infected and mono-infected individual for proper follow-up. All HIV patients, concerning recommendation, all HIV patients tested negative for hepatitis B or C should be vaccinated against hepatitis B and C. In Cameroon, hepatitis B and C tests should be included in the package of tests proposed to patients in Cameroon. Thank you for listening. Sorry for the inconvenience that the audio was not well.
Thank you for the presentation, Dr. Adam. Does anyone have any queries?
Okay, come now.
I hope there are no queries from other listeners. Let's move to the next presentation by Dr. Fernanda from University of Brasilia, Brazil. Dr. Fernanda, are you ready for the presentation?
Yes.
Okay, I'm making you as a presenter. You can share your screen.
Okay, thank you.
You are now the presenter. Continue with the speech.
Whoa. Ai, como é que eu faço aqui? It's not good.
You can make it full screen. The option will be at the
Yes.
bottom. Yes, yes.
Ah, oh my God. No, 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 no. Será que é aqui?
On the bottom, yes, yes. Next to that, just move the mouse. Next, on the bottom, on the bottom.
For a minute, please. Oh my God. That's okay?
Yes, we can see your screen. That's perfect.
Good morning. My name is Fernanda. I'm a nurse. I'm from Brazil. And today I speak about environment and social factors on the incidence of tuberculosis in 3 Brazilian municipalities and in federal district. Tuberculosis is contagious disease associated with purple, malnutrition, low income, alcohol and tobacco use. And like down, I run a minute aqui. Basic sanitation, as well as climate factors and air pollution. The coefficient of incidence of tuberculosis in Rio de Janeiro, Recife, Porto Alegre, and Federal District. In Recife and Porto Alegre is more, and the Federal District is less. Research question. The Federal District has a low incidence of TB when compared to the municipal's incidence. But what could contribute to this scenario? Climate, social indicators. Objective. Analyze the effects of environment and social factors on tuberculosis incidence in 3 Brazilian municipalities and in the Federal District of Brazil. Methods. An ecological and descriptive study. Here is Recife. Here is Federal District. Here is Rio de Janeiro. And here, Porto Alegre. The population involved 74 Uncle 080 cases from Rio de Janeiro, 24 Uncle 422 from Porto Alegre, 29 Uncle 590 from Recife, and 3 Uncle 484 from the Federal District, for a total of 131 Uncle 576 TB cases between 2003 and 2014. Incidence early. Inclusive criteria. Cases of pulmonary, extrapulmonary, and pulmonary extrapulmonary. TB and reside in the Federal District, Rio de Janeiro, Recife, and Porto Alegre. Exclusion criteria. Cases of non-resident TB and those with change of diagnosis. Analysis variable. TB, new case. Climate variables. Temperature, solar radiation, wind speed, precipitation, water vapor pressure, and altitude. Social indicators. Mean of people, per household, per capita income, drinking water supply, sewage treatment, garbage collection, percentage of illiterate, and the number of bathrooms per house field. And data analysis, TB new cases, SINA, climate information for World Clean version 2, and socioeconomic data from the Brasilia Institute of Geography and Statistics. And here, this statistic using basic regression, multiple regression, and binary regression. Results. Distribution of tuberculosis cases according to clinical and demographic characteristics of the Federal District, Porto Alegre, Recife, and Rio de Janeiro. And observed a predominance of TB in men, okay, men. The most affected age group was 31 to 45 years. In Recife, Porto Alegre, and Federal District. In Rio de Janeiro, the age group of 50, yes, 50. Oh, 60, sorry, 60 to 30 years. TB was more frequent with people, okay, in Porto Alegre, Recife, Rio de Janeiro, in Federal District. And bacilloscopy was positive in 38% of the patients, and the spoon microscopic was mostly spoon culture positive and not performance. Yes. And in table 2, estimatives of the risk for TB infection according to environment variables in the univariate analysis, Federal District, Recife, Porto Alegre, and Rio de Janeiro. Environment, precipitation, regions, temperature, vapor, wind, and altitude. Regarding environment condition, we verify that the Federal District showed a lower risk of TB infection than the other municipalities. And temperature, vapor, and wind parameters were available in Federal District. On the other hand, the low wind velocity and the vapor contribute to the reduction of TB infection in relation to the other municipalities. In this case, wind speed and vapor in the risk of developing TB when comparing the 3 municipalities with the Federal District. Estimatives of the risk for TB infection according to social variable in the unity analysis. Social variables: people, household, drink water, SIG Treatment, Waste Collection, Bathroom, Household, Illiteracy, Per Capita Income. The lack of a bathroom at home indicates a fold higher risk of developing TB in Porto Alegre, 100-fold in Recife, and 37 in Rio de Janeiro, compared to the Federal District. Also, the lack of garbage collection increased by 49 times the risk of having TB in Recife, 38 Porto Alegre, and 23 times in Rio de Janeiro, in comparison with the Federal District. The lack of treatment water contribute with a risk for TB in Recife and Porto Alegre and Rio de Janeiro when compared to the Federal District. Estimates of tuberculosis risk rate according to social and environment variable by municipalities in the I can't. Municipal and variable. Federal District. Risk rate for garbage. To Porto Alegre, risk rate for TB in temperature. Recife, risk rate for bathroom, water, income. In Rio de Janeiro, risk rate, the risk for TB infection were precipitation, region, temperature, vapor, wind, lack of bathroom, water, and sewage. Well, this present study revealed the existence of an association between incidence of TB and environment and social conditions, and these relationships present difference in the risk depend on the territory and the environment situations where the disease is found. Finally, it was possible to understand that the health sector should, together with other public policies, such as infrastructure design strategies to support the implementation of a policy involving large cities in order to reduce burden of TB in the peripheries of large urban agglomeration. In addition, there is a need for urban and environment planning in the large Brazilian capitals with a view to improving the population's living conditions. The reference and the analogy. Thank you very much.
Thank you for the presentation, Dr. Fernanda. Does anyone have any queries related to the presentation by Dr. Fernanda? I hope there are no queries.
Okay, thank you.
The next session is by Dr. Valerie. Dr. Valerie, are you ready for the presentation?
Yes, I am ready.
Okay, I'm making you as a presenter.
Yeah, thank you.
You are the presenter, Dr. Valerie.
Yeah, I have no screen of my. Ah, yes, yes, I see. Can I do it some bigger? It is not.
Yes, just tap on the screen. You can share your screen by tapping on that.
Where is green? Skip. No, please close confidential. Confidential. I don't know. I cannot see the text.
Are you able to see mic, camera, screen, and leave option?
Yeah, I see the screen.
Yes, yes.
I made by presenter.
Yes, just tap on
Yeah,
the screen so that we can see your computer.
screen. Yeah,
Yes, tap on the
yeah,
screen.
screen.
Just.
Okay, I push it. It's going to show.
Did you press on it?
No, I cannot do anything. I have not my presentation.
Just to confirm, are you using your computer or a smartphone?
Sorry. Can I open the presentation myself?
Yes, yes, yes.
Yes. Yes. Okay.
Yes.
Yes. Okay.
But it would be good if you share the screen so that
Okay. Now I see my presentation. Okay. Oh.
we can't see your screen, Dr. Valerie.
Yeah, I can see. But yeah,
Just do
yeah.
one thing. Are you able to see the options like mic, camera, screen, and leave option?
Where is it?
On the bottom of the screen, you can see the
Ah,
option.
yeah. Yeah. Option.
Just tap on the screen so that we can view your presentation.
Ah.
Did you got it?
No, I cannot find it. And
All right. You can do one thing. You can share me the presentation via WhatsApp so that I will share the screen and you can speak about it.
I push the screen option. Yeah. And I see my presentation. If it's possible to begin, I can.
Just a moment, Dr. Valerie.
Yeah.
We can't see your presentation, Dr. Valerie.
Yeah,
Can you share the presentation via email or else WhatsApp so that I can share my screen?
share. I can push share.
Yeah, yeah,
Yes. Yeah.
yeah.
Okay. Okay. Share. Okay. I see. So that's all. I see my presentation. Can I begin?
Yes, yes, yes. We can
Yes.
see your presentation. Yes.
Yeah.
Continue with your speech.
Okay. Okay.
Yes, doctor.
So, good afternoon, listener. I'm going to tell you about evolution of ancient medical dream concerning the possibility to influence on the epidemic dynamics. And in this presentation, we will consider as a case an epidemic in a city. It will be
Dr. Valerie, sorry to interrupt you. Can you full screen the presentation?
screen.
Yes, yes.
What?
The
Where?
option will be on the bottom side.
Bottom.
Bottom. Come to the bottom. On the right bottom.
Right. Bottom.
Move right, move right.
Oh,
No, no,
sorry.
not that.
No, not it, of course. But where is bottom?
Same, like that. Come down, come down.
Can you see my
Yes, I can see your cursor. Just come down. Just come down. Yes.
Yeah, this
Down,
one.
more down, more
Okay.
down.
Okay.
You can. No, 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 no.
No.
I can't see your presentation. You have closed it.
Leave meeting. No.
Oh. Once again, share the screen, Dr. Valerie.
So please, please speak slowly because I cannot name of all push, all push, all
Okay,
button.
okay.
What I can do, what I have to do.
Are you able to see the MIC, camera, screen, and leave option on the screen?
No.
I just want to know what exactly you are able to see on the screen.
Screen, yes.
Just
Okay.
tap on the screen so that we can see your presentation.
But I cannot see the presentation itself because it is very, very small letters. I cannot read the things.
All right. You do one thing, share the PPT via email so that I will share my screen and you can deliver the speech.
Okay. Can you help me to do the paper that to do the work that I cannot do? I ask you about this on the telephone, smartphone.
Yes, yes, yes.
Because I don't know. It is my first visit to your application.
Yes, I can understand, Dr. Valerie.
Yeah.
Are you able to see the option called screen?
Screen. Where is
Yeah.
share my screen? Yeah.
Yes, yes.
It
Share
is
screen.
name of Windows. Yeah. Share screen. Yeah.
Yes, tap on it.
I push it. Close the screen to share.
Yes, tap on yes.
Yeah. And now screen, but there is no any consequences.
Okay. You do one thing, doctor. Can you send me the presentation to your to my email?
Send your presentation.
Yes,
Send my
yes.
presentation to you. Yeah.
Yes, yes, yes.
Yes. Okay. Yeah. I try to do it. Oh. Oh. Короче, сохранить как? Сохранить. Save as. Yeah. How can I transmit you the presentation? Can you see my screen? Because there you have my presentation.
No,
My
doctor,
screen.
we cannot see your screen.
Mm,
Just do one thing. Just log out and log in again.
Morgan. I cannot understand how to do it.
Just close the app and I have sent you a link. Just tap on the link so that you can log in back.
Link. Skip preview, include. Управление презентацией. Это все не то. Сведения. No, I cannot do what you ask about.
Okay, doctor, not a problem. We will figure it out in the next session. I mean, next presentation. Let's give a chance to
Yeah.
Dr. Ritu so that we
Yeah.
can continue our webinar.
Yeah.
Dr. Ritu, are you
Try
ready for the presentation?
to write me about the exact what I have to do. Yeah.
Yes. I will send you an email.
During
Then.
this presentation. Okay.
Yes. After this, you
Yeah,
can.
hi.
Yeah,
Yeah,
Dr.
hi.
Ritu.
Just tell me how to present how to share the screen.
Yes. Are you
Can you hear
logged
me?
in from? Yes. Are you logged in from computer or a smartphone?
From my laptop. Yeah.
Okay. I will make you as a presenter. After that, you will have an option called screen sharing option.
Okay.
Just a moment. I'm making you as a presenter. Dr. Ritu, I made you as a presenter. You can now share the screen. Yes, we can able to see your screen.
How do I go to screen share? I mean
On the bottom, you will have an option. Like, are you able to see the maximize or minimize? Yes. Just tap on it. Yes. Perfect.
Yeah, and I just need to close.
You can use the arrow button to change the slides.
No, actually this thing is coming on the side, the go to meeting part. So I just want to okay, I've just collapsed. Fine, I've been able to do it. So I'll start. You can hear me. You can see the PPT.
Yes, yes, yes. We can hear you and we can see your PPT. Just continue the presentation.
Yeah, so this is about this presentation is about the phenotypic susceptibility testing of Mycobacterium TB in reference to rifampicin antibiotic, and it is about genotypic characterization of inferred mutations in genotype MTBDR plus SA and its association with phenotypic susceptibility. Basically, there is a test called as LPA, which is genotype MTBDR plus for diagnosis of MDR-TB. It tells you about both rifampicin and INH. It is an WHO endorsed test. It's a rapid test as for all molecular tests. Basically, it's based on reverse hybridization of amplified products to probes immobilized on the membrane. These probes cover few bases of wild type sequence and specific mutation at single base of RPOB, CATG, and INHA promoter region. Right? Single base of RPOB, CATG, and INHA. That is what RPOB. So these probes are covering here, as you can see on the right. So RPOB is there, CATG is there, and INHA. And as you can see, RPOB wild type and mutant. That is what. So presence of either an absence. So absence of hybridization to wild type probe and mutant probe. That is, if again we are going to the previous screen, if we see that absence of any of the probes along with the presence of a mutant probe is called as the actual specific mutation. But if you're going to talk about the absence of the probe only, that is going to be inferred mutation. So this absence is inferred mutation and it is suggested to be interpreted as rifampicin resistance. So then the GLI has given this guideline of line probe assay for drug resistance TB detection, right? So here you have identification of MTB complex and its resistance to rifampicin and or isoniazid using genotype MTB-DR+. So we have rifampicin RPOB, right, where you have this missing WT7, right, is missing. And here, you can see that mutant is present. So this is not an inferred mutation. Whereas if you see this one, you have a mutation, you have a wild type missing, but you don't have any mutant present. So this is an inferred mutation. So this one, actually, the right one on the number 5th strip is the inferred mutation. Now, these could be due to the presence of either silent mutation in that particular region, not causing resistance, or some rare mutations, or maybe some specific mutations which have not been captured on the strip. So as we can understand, 4 specific mutations are the ones which have been taken based on their commonality, means how common they are. But that does not mean they are the only mutation. They may be other ones. So then, GLI says that you can report these mutations as resistance without the necessity of confirmation. Possibility, if there is silent mutation and disputed mutation, it can generate ambiguity in reports. Deciphering exact genotypic nature of such mutation and association with phenotypic resistance is hence essential. So if you decipher the exact genotypic nature and association with phenotypic resistance, it is very, very essential. To characterize, you have inferred mutations, confirm identity of inferred mutation by DNA sequencing, and to compare the inferred mutations with phenotypic ASD for rifampicin. So first objective was to first identify what is inferred mutation, then confirm it by sequencing of RPOB RRDR region, and also just to have a comparison with the phenotypic DSD. So in the methodology, presumptive MDR-TB patients, 10,000 were screened prospectively from 2016 to 17, and the patients having inferred mutations were identified in culture. Target sequencing was performed on 506 base pair region from codon 340 to codon 509, which encompassed the 81 base pair rifampicin resistance determining region of the RPOB gene using in-house primer set. So 0.5 ml positive MTB culture was inoculated into rifampicin midget 1 microgram per ml culture and intubated till positive to detect phenotypic rifampicin risk. As far as the results is concerned, so 10,000 TB cases were screened in the study at NRL. These included the rifampicin resistance with mutation, which were N is equal to 2123. Inferred mutation is N is equal to 341, which were 16.1% were inferred. And isolates with phenotypic susceptibility and sequencing results were available, and they were enrolled in study as N is equal to 203. These included phenotypically sensitive as 31.5%, 64, and resistant as 68.5%. So, so interesting thing is that even though these are inferred mutations, they have been reported as resistant. On phenotypic testing, one could see that many of them could be sensitive, and most of them were still resistant. And let's see why. So, which was the most frequently detected inferred mutation? This was WT8 in 34%, followed by WT4 in 21.6% and WT2 in 20.2%. Commonest SNPs detected on sequencing were 531W, which is 22.6%, D516Y, 15.3%, H526N, 10.3%, and L511P, which is 9.3%. Now, these include the 22.6%, 15.3%, 10.3%, and 9.3%. Right? So, these are the mutation that you see here. So 3 isolates showed wild-type pattern on sequencing. Mutations detected by DNA sequencing in various absent wild-type probes in LP and phenotypically rifampicin susceptible isolates in midget AST were N is equal to 64. Commonest mutations detected among phenotypically rifampicin susceptible isolates were D516Y, followed by 526N, 511P, 533P, and 526L. So these were the commonest mutations. So if you can see, these are the regions where these were the ones where you have arrow L51P, and then you have D516Y, and then you have H526L, H526N, and L533P. So these 3 isolates actually also showed wild-type pattern on sequencing. So what we observed was a high discordance of about 30% between genotypic and phenotypic ASD in case of inferred mutations. This is higher than most studies which study the phenotypic and genotypic concordance, but point to be noted here is that most studies have not, they have taken all sorts of strains which have inferred mutations or otherwise mutations. In this, we have specifically focused only on inferred. So what could be the reason? Because of discordance could be because of the type of mutation, because as we know, mutations D516Y, H526N, L511P, and L533P are disputed because they anyways show rifampicin susceptibility in most strains. It is known fact that they tend to show susceptibility because of the low MIC concentration, whereas somewhere they also show rifampicin resistance. Also, the phenotypic rifampicin DST performed, which is in widget, has a critical concentration, which sometimes also may not be accurate and may not be sensitive to detect the low-level mutations. So sometimes low-level mutations are identified as sensitive, whereas they may be resistant. Discordance between midget and genotypic AST with inferred mutations cautions reporting of false resistance due to silent mutations and the need to redefine midget cutoff concentrations for rifampicin resistance. Then the novel RPOB mutations found in MTB isolates by DNA sequencing. Here, 27 or 13.3% isolates showed mutations not reported earlier, confirmed to the best of our knowledge after extensive literature search, which included SNPs, insertions, and deletions. SNPs were 22, insertions are 2, and deletions are 3. Majority, that is 83.1% of novel mutations, were phenotypically resistant to midget, while only 4 or 14.8% were sensitive, and however, significance of these mutations couldn't be ascertained due to lack of previous data. So 13.3% isolates showed mutations which were not reported earlier, confirmed to the best of our knowledge, which included SNPs, insertions, and deletions. So this is one very interesting finding. And the majority of novel mutations which were found, like which were not reported earlier, but actually phenotypically resistant, which also shows that they could be significant, but still, because they're novel mutations, one really can't say sure shot. So present study is very unique as it focuses on inferred mutations only. It is suggested that mutant flow, because the commonest was S513W, may be added, because when people are reporting inferred mutations sometimes can be missed. So this will add to better sensitivity, accuracy, and specificity of LPA. Presence of silent mutations amongst the inferred mutations, so cautions over reporting if solely done on absence of wild type. So such strains should be tested on lower concentration in midget or on LJ. The important thing is, though the program in India or otherwise people say that even GLI says it reported, but still because it can lead to silent mutations, so such strains should be tested ideally on LJ or maybe by reducing the concentration in midget. Similarly, the novel mutation which is showing resistance or sensitive, by putting the complete MIC, some reference needs to be standard and significance needs to be given. And the probable key to this puzzle lies in studying treatment outcomes of the patients with inferred mutations to establish and determine their significance. Thank you so much.
Does anyone have any queries? I hope there are no queries.
Yes.
All right,
Excuse
Dr.
me.
Fernanda. Yes.
Uh,
Yes. Go ahead.
there are a difference in the genotypic and phenotypic, or it's necessary more studies or no?
So, ma'am, in this particular study, we found more difference between genotypic and phenotypic than normally reported. It could be because of the type of mutations. We are just studying the inferred mutations due to the absence of wild type. And as I said earlier also, that it could also be because the many of these mutations are low level mutations, and the MIC which is being used, the breakpoint concentration which was being used was a little higher. So if we probably use a lesser breakpoint concentration, so maybe we would get better result.
Okay, thank you.
Does anyone have any query? All right, then. Now the next presenter is Dr. Rajni. Are you ready for the presentation?
Yes, Brian, I'm ready. Can you hear me?
Yes, I can hear you. I am making you
Yeah.
as a presenter.
Okay.
You are the presenter right now.
Can you see my screen?
Yes, I can see your screen.
Is it full screen or?
No, we are just tap on it.
Okay,
Yes, yes,
I'm doing slideshow.
yes. Perfect.
Okay. Yeah, a very good evening to all of you. So I'm Rajni Garg. Currently, I'm working as a CSIR pool scientist in IMTech. So today I'll be presenting work that I have done in Indian Institute of Science while I was DST Inspire faculty there. Thank you, Brian, for the invitation for this conference. So I'll be talking about my work. It is CTPF mediated calcium flux is required for MTB survival in macrophages. So tuberculosis has been introduced by our earlier speakers, Dr. Mamta. So I think these audience don't need an introduction to tuberculosis. In fact, Dr. Ritu also spoke about tuberculosis. So I'll tell you what was the motivation behind doing this study. So when I was doing my PhD, I worked on MTB and I found out that I learned that MTB, it basically in 95% of the times the infection is latent and only 5% of the times the infection is active. So TB is in active infection, you have TB is caused by metabolically active bacilli. They are replicating and they are susceptible to drugs that inhibit the processes essential for growth. But latent infection is caused by dormant, non-replicating bacilli, and they maintain full viability at a very low metabolic rate. Also, they are resistant to drugs. So the question that was there in my mind, that how can we understand this latency or dormancy? So there are previous reports which tells that in dormancy there are certain genes which are upregulated. So I thought that in order to understand dormancy mechanisms, we need to characterize these particular genes, these proteins which are upregulated in dormancy. So in two separate studies, it was found that 48 genes are upregulated in MTB during dormancy. So these genes are regulated by DEV-RS two-component system. So they are part of this dormancy regulon, and CTPF is one of them, the particular protein on which I worked. CTPF stands for, it's a probable metal cation transporter. So CTPF was upregulated in conditions of nitric oxide, in conditions of hypoxia. So these are the stresses which are prevalent in the macrophages. And when MTB goes inside our body, it resides in macrophages and it experiences these stresses. So if we see this pictorially, so when MTB is inside the phagosome, it experiences these stresses, which are reactive nitrogen intermediates, nitric oxide, carbon monoxide, hypoxia. So these all are known to be signals for dormancy. And this particular protein, CTPF, is actually P-type ATPase, and it is present in conditions when the cells are treated with when the bacilli are treated with antitubercular drugs, as well as there are certain reports which suggested that it is present in early stages of infection, as well as in non-replicating persistence 1 and persistent stage 2. So we wanted to see like what this particular protein has to do with infection. So first we wanted to see what this particular protein do in early stages of infection. My pointer is stuck. My slides are stuck.
Just press the arrow.
Okay. I'm pressing the arrow down, but
All right, do one thing. Just press escape.
okay.
Is it working?
No.
Close the slideshow and just again log in. I mean, just open it again.
Shall I stop share and then?
No.
Because
Just enter.
escape is not working, right?
Okay. You can stop the sharing and you can do it again. I will make you the presenter again.
Okay, I'm sorry. I don't know why that happened.
Now you can do it again by sharing the screen. Is it working now?
No, it's still not going ahead actually. Okay, yeah,
Yes.
it worked. So as I was telling that CTPF is a P-type ATPase. So what are P-type ATPases? These proteins are present in all domains of life and they maintain ion gradient across the cell membrane. So there are different types of P-type ATPases. They all have 5 structural domains, out of which 3 are cytoplasmic and 2 are membrane localized. So they are very big proteins, and the membrane domain itself is very huge. It has something like 10 transmembrane helices. And they oscillate between 2 conformational regimens, E1 and E2. So what happens is that like these proteins, they on the basis of ATP hydrolysis, they transfer the calcium out, the particular metal ion out. In our case, it will be calcium, as I will be telling in subsequent slides. So it binds to ATP, it hydrolyzes ATP, and then it uses that energy for a conformational change to happen. And in that process, it effluxes the metal ion. So in MTB genome, there are 12 P-type ATPases, which have different metal ion specificities. So first we did some bioinformatic analysis to find out like what exactly CTPF does. So we took mycobacterium from all the from the tuberculosis species, Africanum, bovis, cannati, microti, also the non-pathogenic M. smegmatis and other actinomycetes. And we did a multiple sequence alignment to find out like what are the conserved residues. So these residues which you can see, these are the conserved ones which are there, which are in white against a red background, and the blue boxes which have the similar residues. So you can see that this particular protein is highly conserved across all these species. So it must be doing something important, we thought, because it is highly conserved. So this is all multiple sequence alignment throughout the protein sequence. We did homology modeling then. So we used sarcoendoplasmic reticulum calcium ATPase. So CTPF had highest similarity with PDB structure of sarcoendoplasmic reticulum calcium ATPase. So this is the model structure using modeler, and the colors are according to N to C terminal. So these are like rainbow colors. So the blue one is the N terminal and the red one is the C terminal. And these are all the domains that you can see. So this is ATP binding domain, this is phosphorylation domain, the substrate binding domain, and the transmembrane transport domain, which has the probable calcium binding residues, and the nucleotide binding domain. So when these structures were superposed, it was found that these residues, we have almost very high conservation of these putative calcium binding residues. So we had pretty good indication that this particular protein might be a calcium binding protein, and it might be a calcium transporting P-type ATPase. So then we did multiple sequence alignment of this particular protein with calcium ATPases with other calcium ATPases, what we see in human, pig, rabbit, and bovine. And here again, we saw a very high conservation. like these white residues against the red background, they are highly conserved, and the blue boxed ones are the similar residues. So here again, we found a lot of conservation. So then the next step was to show that to purify the protein and to show whether actually it has that ATPase activity and the calcium binding activity. So since this protein was very complex, so we tried a lot of methods for purification of the recombinant protein. So we tried E. coli as well as M. smegmatis, but the protein concentration that we got was very less for doing these assays. So then we came across these particular papers in which, when they are working with highly complex transmembrane proteins, what they do is they isolate the membrane vesicles which express those proteins and not the protein itself. So this is a Candida protein ABC transporter CDR1P, in which they take out the membrane vesicles and then they show the activity. Similarly, there was another paper from the membrane vesicles of Cucumis sativus roots, and it has proton ATPase activity. So taking cue from these papers, we then isolated the membrane vesicles from M. smegmatis overexpressing CTPF, and we did the activity. So this particular activity was inorganic phosphate estimation. So this was a spectrophotometric based assay, and we estimated the inorganic phosphate release once we give the protein with different metal ions as well as ATP. So we tried with calcium, magnesium, sodium and potassium. So with sodium and potassium, we did not get any activity, but with calcium and magnesium, we got a good activity, with calcium activity being higher than magnesium activity. And then we used EDTA in the reaction. So EDTA, as we all know, is a divalent metal chelator. So when we used it in the reaction, the activity went down for both calcium as well as magnesium. We also used EGTA, which specifically targets magnesium, and then only the magnesium activity, magnesium raised activity, it went down. And when we used a generic inhibitor, sodium orthovanadate, so this is like an ATPase inhibitor, the activity with both calcium and magnesium, it went down. So we were sure that this ATPase activity is specific activity, but we were getting it with both calcium and magnesium. So what was the reason for that? Because all the similarity was there with calcium. So we did certain in vivo assays to be sure that whether this protein actually transports calcium or magnesium. So as I told that we used M. smegmatis for overexpressing the protein. So from now on, we call that strain as MSCTPF strain. So this is a blot which checks that we have an induction of the protein. In the protein was going in pellet. So we did a growth curve to see like when we are overexpressing CTPF, what is happening to the growth of M. smegmatis. So in M. smegmatis wild type, the growth is shown by this pink line, and MS pement is the vector control. The growth is shown by this orange line, and this olive green line. As you can see, the growth is less in MS-CTPF. So this is done in normal 7-9 media with no metal supplements. So when we were supplementing with calcium, we saw that with increasing concentrations of calcium, the growth defect was rescued for MS-CTPF strain, suggesting that in vivo this particular protein is transporting calcium only. And when we did the same experiment with magnesium we could still see some growth defect, suggesting that calcium is the preferred ion for this protein, for transport by this protein in vivo. And since it is a membrane protein, we wanted to see that are there any changes which this particular protein's overexpression is doing in M. smegmatis. So we did biofilm formation, and we saw that this overexpression of this protein, we see very less biofilm as compared to the wild type and the vector control. And when we supplement this particular MSCTPF with calcium and magnesium, with calcium, the biofilm forming capability comes back. With magnesium, it does not come back. And similar was with pellicle formation. So this MSCTPF, it shows lesser pellicle formation, but when supplemented with calcium the pellicle formation is restored. With magnesium, it is restored to some extent, but not to that much extent. We did sliding motility assays also, in which we spread this M. smegmatis on a soft agar plate, and when there is no supplementation, then the sliding motility is very less, the spread of the colony is very less. But when we supplement with calcium, the colony spreads like wild type. With magnesium, this defect does not go, suggesting that calcium is the preferred ion in vivo. So MSCTPF, it was very sick in quite a few aspects, like it had lesser biofilm formation, lesser pellicle formation. Also, MSCTPF cells were longer. So we have done DIC in confocal microscope. So these cells were quite long. So these cells were like in range of 6 to 9 microns, majority of them, while the wild type majority were in 4 to 6 microns, the M. smegmatis size. So these cells had different morphology than the wild type. So having done all this characterization in M. smegmatis, we then moved on to MTB, which is the virulent model, like MTB H37RV. So in order to prove that this protein does something, we have to either knock out the protein or knock down the protein. So we used CRISPR interference technique for conditional knockdown of CTPF. So in this particular technique, we use dCas9 plasmid, which is a dead Cas9. So this particular protein is directed towards our gene of interest by guide RNA. So we designed guide RNA for CTPF, like we designed one towards the proximal end and one towards the distal end. And this particular guide RNA, it directs the dCas9 protein to CTPF transcript, and this acts to the gene, and this acts like a roadblock for RNA polymerase. So it inhibits transcription of the protein, and hence no transcription, the RNA level goes down and the protein level also goes down. So we get a conditional knockdown. So this happens when we give ATC, which is anhydrotetracycline, to the culture. So this acts as an inducer of guide RNA, and thus that thing goes down. The expression of the particular gene goes down. So when we did this guide RNA experiments, we did RT-PCR to see what is happening to CTPF levels. So this is the wild type level, which we took as 1. This is the vector control with both the empty plasmids. And with guide RNA 1, we got significant reduction in CTPF transcript levels. So we further moved on with our studies with SG11. We called it CTPF CKD, and we did a growth curve for MTB-H37RV. So MTB is a very slow growing organism with a doubling time of 24 hours. So we did this growth curve for 12 days, and we found out that CTPF CKD has reduced growth. So it has reduced growth towards late log and stationary phase, not in the early log. So then we found out that it has higher expression in the stationary phase. That is why the growth defect is more pronounced towards the stationary phase. We also saw the CTPF levels in conditions which are prevalent in macrophages, like high acid, nitric oxide, and hypoxia. and we saw a very substantial increase in CTPF transcript level in these conditions. Also, we did intracellular studies, like we infected macrophages with MTB, the vector control, and CTPF-CKD, and after infection, we harvest the bacilli and plate it. So MTB CFU is increasing as expected, but with the CTPF-CKD, it shows decreased CFU, which suggests that CTPF-CKD is attenuated for growth in macrophages. So the next question was that if CTPF is expressed in macrophages in early stages of infection, what exactly it is doing there? So then, since it is a calcium transporter, we wanted to measure the calcium levels in the macrophages when it is infected with MTB. So for this particular experiment, we used these raw macrophages, and then we did this experiment for early time points of infection. So for MTB, 1 hour, 2 hour, and 4 hour are early infection, and we used Fura red dye for this quantification of calcium. So this images are pseudo colored in green. Actually, we get red images, but with green we feel more confident and the results look nice. So this I have pseudo colored to green, and we saw that in uninfected macrophages and in RV infected macrophages, you can see that there's an increase in the overall calcium levels of the macrophages, and when in CTPF knockdown, there's a decrease. Okay, and in 1 hour you can see a decrease, in 2 hour the decrease continues, but in 4 hours you see almost that decrease is not there. So it catches up, the cell, it tries to tries to inhibit what is happening and tries to come back to its normal level. So CTPF has its effect in early stages of infection. We thought we did this experiment, and then we found that CTPF has like the calcium efflux of CTPF is happening and in early stages of infection, and the role is then restricted to early stages of infection. Excuse me. So next we wanted to see that as I told you before, that CTPF-CKD is attenuated in macrophages. So we wanted to link the calcium efflux with the growth of CTPF in macrophages. So we did few blots to see what all the proteins are there in the macrophages and which all proteins, like how can we connect these two things, the calcium efflux and the CTPF growth attenuation. So we found this particular protein mTOR. So mTOR phosphorylation, we found that in CTPF-CKD, phosphorylated mTOR levels are reduced. So mTOR, it inhibits autophagy. The phosphorylated mTOR inhibits autophagy, and thus it helps MTB in survival inside the macrophages. So in CTPF-CKD, the phosphorylated mTOR levels are less. So autophagy is not inhibited. That is why you see these autophagosomes inside CTPF-CKD infected cells. So we concluded that CTPF-mediated calcium flux leads to mTOR-dependent autophagy inhibition in macrophages. And when that CTPF is not there, it is knocked down, mTOR phosphorylation is down, and therefore autophagy inhibition does not take place. So here you can see like LC3B2. So this particular form is an autophagy marker. So it is increased, suggesting that the cells are undergoing autophagy and the bacteria will be cleared. Right? So that is why CTPF-CKD is showing lesser growth in macrophages. So this particular study was published in Frontiers in Cellular and Infection Microbiology last year. So to summarize the study, like in this particular work, we have identified CTPF as a P2A type calcium transporting ATPase. It is upregulated in macrophage stresses like hypoxia, nitric oxide levels, and acidic pH. Using confocal microscopy and fluorimetry, we have shown that CTPF effluxes calcium in macrophages in early stages of MTB infection. So downregulation of CTPF expression by conditional knockdown resulted in perturbation of host calcium levels and decreased activation of mTOR. Here we present a mechanism of how calcium efflux by the pathogen inhibits mTOR-dependent autophagy and enhances bacterial survival. So the future work which I want to do is like how this particular calcium efflux can help mycobacterial persistence and dormancy in the host. So we have seen that this particular protein has a role in early stages of infection, but we also know from the previous work that this particular protein is upregulated in the dormancy regulon. So it might be playing a role in persistence and dormancy. So I want to check that. And since these experiments are really long with MTB and they require lot of funding, so I'm planning to apply for a grant for this particular study. So that's it. I would like to acknowledge Professor V. Nagaraja. He hosted me in IISc for this work, and also DST Inspire Faculty Award. And I would also like to acknowledge CIDR, where I have done most of these experiments. So all the MTB infectious work was done in CIDR, Indian Institute of Science. Thank you, and I'll be happy to take questions.
Thank you for the wonderful presentation, Dr. Rajini.
Thank you, Brian.
Does anyone have any queries? I hope there are no queries. Our next presentation is by Dr. Valerie. Dr. Valerie, are you ready for the presentation?
Yes, I'm ready.
I made you as a presenter. Now you can share the screen as I shown you earlier.
Okay. I push the button.
As I shown you in WhatsApp, did you are you able?
So on your internal screen, yeah, I see my presentation, the first slide of it.
Yes, doctor. Did you tap on the screen option in the
Yeah,
GoTo meetings?
yeah, yeah. I done it.
But we can't see your presentation.
I don't understand.
Just do one thing. Just grant me the access in any desk so that I can enable that option. Now you can present your speech, Dr. Valerie.
Yeah, I can start it. I can
Yes.
start. Yeah.
Yes.
Okay. So, good afternoon, my dear listener. I'm I am here to tell you about some about evolution of ancient medical dream concerning permission peculiar to influence on the epidemic dynamics. And can I switch on this? Where is the option for change the screen, say slide?
Just tap on the arrow mark right side so that it will on your keyboard.
Draw it to. Share something else.
On your keyboard, you just tap on the arrow mark, right arrow mark, so that the slide will move.
I don't see this step button. Where is this button? Where is this button? Sorry. Sorry. Can I do something?
Doctor.
Yeah. I'm here.
Are you able to see the arrow marks on your keyboard?
Aromat? What is it, aromat? What is it?
Just grant me the access of your computer so that I can move it.
Yeah. Access. Now I have to. I cannot shut the. Oh yeah, Embryo. Okay.
Now you can deliver the speech.
Oh, okay. Okay, in this presentation, we will consider as a case an epidemic in a city. And first of all, several words about prehistory. In the first quarter of last century, some first model appeared soon after the Spanish flu, and it was very simple model, very simple supposition, and they based on the on the parameter on the high level, I mean it is number of health people, number of infected people, number of restored people. And of course, this model is bad property that did not include any probability to get infected. But this parameter was included as parameter. But we cannot measure this parameter. And in this first model cannot be used for real cases. So what is it? Sorry. So from the first quarter of last century up to very beginning of this century, scientists tried to modify this model with the object to make the assumption very simple, but the parameter in this modified model is the same. It's the property to be infected. Property to be infected during the meeting. And so this modified model is useless for real cases. Now we can do something. At the very beginning of this century, we are afraid for coming the new pandemic, avian flu, as you remember. And there was organized some preparation company under the guide of United Nations. And at this time, we have had the computers with great memory and very quick velocity. And so in the frame of this preparation to possible coming the new pandemic, we not we, but several investigation group at the different university at the beginning and later in some other country were financed and asked about the possible new approach to the creating the model for epidemic dynamics. And because of good computers, the idea of computer imitation of real life of resident was on the first place. What we understand on the word imitation. Demographic and infrastructure data gave us an opportunity to prescribe the number of virtual residents. It's their name in computer is agent, their age distribution, the number of number of household and its family composition, and the number of working places, I mean daycare, kindergarten, school, bar, farm, institute, and so on, and composition of workers in any of them. In any of them. Okay. Basic assumption for some repetition of real life of people in the city is the following: several age groups, constant probability to get infected during the contact in each group, and deaths are ignored. Imitation process. Every working day, all health and infected agents not having doctor's diagnosis go to their working places. During this process, we count number of common agent to any working places, and also we count number of infections among them. And now, if we know the probability to get infected, we can calculate number of new infected agent during these working days. At the very beginning of this century, many of this group published pioneer paper in which they proposed a new approach to the creation of model, and all this paper contains some subsection where the problem was follows. How can we calculate the probability to get infected if you have some city where the epidemic has finished already, and we have data from surveillance center. This problem is very strange one because it can have unique solution. It have many solution and have no solution at all. Moreover, if you try to compute this numerical solution this problem, this procedure became unstable. So this problem, it's funny, this problem has medical name, Ilpo's problem, and mathematician during several years ago, I think, propose some modification special for solution Ilpo's problem, and according to this this supposition, you can have numerically, you can solve numerically this Ilpo's problem that we are talking about. Okay, of course we can remark this collective error because it's present in all pioneer paper. It is very interesting situation when you have a collective error. I tried to find the reason for that, and found it in the fact that most of mathematical program in university, many West country cannot have not contain some section for ill-posed problem. Okay, so we carry out some computational experiment and have some results of it. Sorry. We take the contact network from Dresden and arbitrary value of probabilities to get infected in 4 ages, age group, and try to computate these from epidemic dynamics, compute the probability to get infected. At this slide, you can see the results. Here you see the given dynamics in Dresden and restored dynamics in the age group and in whole city. So you can see that compare these two results, we can say that comparison with very good. Now let us look at the detail of what we have done right now. In some city under consideration, the epidemic has finished. We have got the epidemics dynamics from surveillance center, and then we use it for calculation of probability, and at last we use this probability for calculation the epidemic dynamics. Look at that. Is it the time to apply to Schnabel price? The answer is no, because we forgot about intervention. As you know, of course, the intervention is some administration action that can reduce the contact network. For example, its time, duration, and percent of online agent. We used it in the today pandemic, and the second example is time, duration, and procedure of school closing, and many other. If we have the new model, we can have the in the source in the city under consideration, the epidemic has finished. We have the dynamics, and we, as we know now, we can calculate the probability to be infected in all age group. So because of assumption under which we make our model, this probability to get infected is the same during the epidemic. It means that we can use this probability for our city under consideration, and look for different intervention. How can we change the contact network? It means that carrying out some calculation, we can optimize the complex intervention that we can done from the medical point of view and economical point of view. And it is natural we can select from this result of such a imitation that is more optimal for us from 2 point view. I think it is very, very step forward. And now I would like to say some words, not too many, about the pandemic, especially about pandemic, today pandemic. What do we have? But sorry. Okay. Pandemic, as you know, pandemic is the epidemic worldwide, and if we have some simple epidemic when we have no I forgot the word. Okay, it is simple epidemic where you have no different wave and different kind of this virus. And in this case, you can use the approach that I talked about earlier. So, if before outbreak, we have to create a contact network for all cities that will be under consideration later, and collection of necessary information takes some time, of course. It should contain detailed data about intervention that will use during this pandemic, simple pandemic. If it is available, it is possible to use the procedure described earlier with the source city and probability to get infected, and the same picture that was in regional epidemic. Now, let us remark about the peculiarity of today's pandemic. This pandemic is very, very high probability to get infected during the contact. It's small time for the first reaction, sharp reduction of contact network and extension of medical base in the country under consideration to come in and especially beginning outbreak. The next latency period is equal to 0. Moreover, an infected individual becomes infectious one practically at the same time, and it can infect several people before hospitalization. I personally read about some hero who can infect 1,500 people before his meeting to hospital. And mathematically, it means that statistical data can be inaccurate, to put it mildly, because latency period is equal to 0. And at last, yeah, our virus is a multi-virus strain, the today pandemic. Unfortunately, at the moment, we have no necessary information for suggest some algorithm for modeling as such epidemic dynamics. So we have to wait for the maybe some time necessary to gather all information that's necessary for thinking about the new approach in the development of model of pandemic dynamics. So unfortunately, let us wait for more universal vaccines and other medicine. Thank you for your attention. Okay. Hello.
Thank you for the presentation, doctor.
Yeah, it's the end of presentation.
Does anyone have any queries? I hope there are no queries from other listeners. Let's move to the next presentation by Dr. Lauren.
Thank you.
Dr. Lauren, are you ready for the presentation? Dr. Lauren? Dr. Lauren, are you able to hear me?
Hello. Please share your
Dr. Lauren, are you able to hear me? Dr. Lauren, can you hear me? Just unmute yourself. Like, are you able to see the mic option, mic, camera, screen, and leave option?
Yes, right. Log in again, please. You are not there. You are out now. You are out now. Again, you are. Please log in again.
Hello all. Dr. Lauren is facing the technical issues. Kindly be patient for 5 minutes. We'll continue the session in 5 minutes. I appreciate your patience.